Okay. So, hello student, good evening to all of you. I hope I am audible and visible at your end. So, I can see many of you have joined. So, just let me know whether I am clearly audible and visible at your end. Good evening, good evening. Hindi, English. Okay, so mostly it will be in English, but little Hindi chal jata hai, theek hai na? So, okay, thank you so much. Hindi, English. My Hindi, okay, no issue. So, we are going to start the LRR session for physiology, okay. So, in this LRR session, what we are going to do, we are going to discuss most important topics of physiology, and these important topics is based on the last 5-year trend of questions, right. So, I have gone through all the questions of the last 5 years. So, some of the MCQs I have kept in this session, so that you can also revise the last 3-year MCQs at least, plus the most important topics which has been asked in the last 3 to 5-year exam. Those important topics will go for a quick revision, right. So, volume check please, team, just check the volume. Okay. So, yes, it will be equally benefit for the FMGE also as well as for INI-CET entrance examination also, because some of the topics are very common in all of the cases. So, okay, we are increasing the volume, we are checking it, no problem, no problem. बहुत जल्दी impatient हो जाते हो आप लोग. Okay, so okay, now check the volume. Okay, okay, आप ठीक है, आप ठीक है, now fine. Okay, so what I was talking about, that in this LRR session, what we are going to do, we are going to discuss the most important topics of the physiology which you should at least revise before going into your exam hall. Okay, because I know ki there are 19 subjects and there are major subjects also. So, most of the cases what happens, you may not get enough time for revision of the physiology topic, right. Okay. So, that is why I am here to give you a quick revision of the most important topics which has been asked in the last 3 to 5 years, and some of the MCQs which you should revise, because we say that always before entering into exam hall, please look at the last 3 years PYQ at least. Okay. So, that is the main target of this session. Now, before the actual session, so this announcement, I believe all of you know that Champions exam is now live in the PrepLadder app. So, please attend this exam for INI-CET entrance examination. So, this is from 23rd to 27th of April, and the benefit of this exam is that the pattern is similar to that of the INI-CET exam pattern, that is a 4 session, 50 question, 40 minutes each, and audio explanation of all the questions will be given. So, you can quickly revise on the go, right. So, these are the few benefits of this Champions exam. So, I believe that already you have, some of you have already attempted the exam, and whoever have not attempted yet, please do it, because it will be beneficial for you only. Okay. Now, before entering into the actual session, look at the what are the important topics that you should revise. Okay. So, suppose after finishing this LRR session, you want to revise that what are the most important topics I should revise from my own note, right, or whatever note you are following. So, these are the important topics which you should revise before entering into exam hall. So, from the general physiology, the different topic has been written. So, I am not going to read all of these topics, because you will get the PDF, the annotated PDF of this session you will get, and that PDF will be available in the PrepLadder app, right. So, you can download from there. So, I am not going to read all of these topics, but you can find out here that the topics has been mentioned. So, please try to revise at least these topics which has been written here, right. Same like that of the RRR. RRR is a little bit more detailed like that. So, total RRR if you look at, so that is around 10 to 12 hours. So, this session will be around 2 to 3 hours. So, that is why the time difference is there. So, obviously content difference is going to be there. Okay. So, this is not absolutely RRR. So, this is the known as the last resort revision. Okay. So, what is the last resort? Could you recall, there is a reflex in our cardiovascular system which is known as the last ditch response or last resort reflex in the body. Could anybody tell me the name of that reflex? So, whenever a person is getting more and more hypotension, blood volume is becoming more and more lower. So, first the baroreceptor reflex will be activated, followed by the chemoreceptor reflex, and then the last reflex will be activated, which will try to revive your blood pressure, and if that is not revived, then the person is going to die, and that is why the reflex is known as the last resort reflex or the, yes, so that is CNS ischemic response. Very good, that is the CNS ischemic response, right. So, CNS ischemic response, one variety of the CNS ischemic response is the Cushing response, that you are absolutely correct, right, but the name of that reflex is the CNS ischemic response, which is known as the last ditch response or the last resort, right. So, now we are going to start the actual session. So, first we are going to start with the neurophysiology. Okay, one MCQ is coming in front of you. Okay. So, try to answer this question, very simple MCQ, but this is a question which has been asked in the last 3 year NEET PG. Okay. So, those MCQ I have kept here, which is which has been asked in the last 3 years exam in the NEET PG, right. So, what is the answer of this question? So, all of you can easily answer this question. That question is asking about the RMP. Okay. So, resting membrane potential of a cell has been given minus 70 millivolt, but whether it is minus 70 millivolt or whether it is minus 90 millivolt is the resting membrane potential. The ions which is most importantly responsible for the resting membrane potential is the potassium ion. So, never forget this, that resting membrane potential is maintained by leak channels. So, there are various leak channels on the cell membrane in resting condition. So, because of the presence of these leak channels, there will be diffusions of ions, and because of the diffusion there will be an equilibrium condition, and at that equilibrium condition if you measure the potential difference between inside and outside the cell membrane, that potential difference is the resting membrane potential. Now, if I ask you that which leak channels is maximally present in resting condition of the cell, potassium leak channel followed by chloride leak channel followed by sodium leak channel. That is why the contribution of the potassium leak channel is maximum for the resting membrane potential followed by chloride followed by sodium. So, the answer of this question here is clear cut potassium answer. But now, here you have to look at one thing very carefully. Okay. So, that what is that thing? So, I just told you that if the question is asking that what is the permeability of the ion in resting condition of the cells, I just told you potassium followed by chloride followed by sodium. So, question if they are asking that resting membrane potential of the cell is close to the equilibrium potential. So, note down this word, if the question is asking about the close to equilibrium potential of which ion, then it is the potassium ion. So, it may be RMP of neuron, it may be RMP of skeletal muscle, it may be RMP of the myocardium, whatever cell it may be. But whenever the question is RMP is close to, the meaning of this question is that RMP is mainly due to which ion, because if the permeability of the one ion is maximum, then the RMP will be close to that ion because of the permeability, right. So, whenever the question is close to, then this is the answer. But you know, next two question that has been written here, or the next two line that has been written here, here the close to what is not there, the equal to what is there. So, equal to equilibrium potential of which ion? Now, you have to remember that the equilibrium potential of sodium, who will tell me the answer? What is the equilibrium potential of sodium? Tell me, write your answer. What is the equilibrium potential of sodium? I am writing the equilibrium potential of potassium is minus 90 millivolt. You tell me what is the equilibrium potential of sodium, and then the equilibrium potential of calcium is plus 130 millivolt, okay, or 132 millivolt. So, sodium, potassium, calcium, and equilibrium potential of chloride is minus 70 millivolt, minus 70 millivolt. Very good, absolutely great. So, I am getting the answer of plus 63 or plus 61, whatever, the plus 60 or plus 63 up to plus 61, this is okay. So, plus 61 millivolt is the equilibrium potential of sodium, and the other equilibrium potential I have written here, the potassium equilibrium potential, okay, and the chloride equilibrium potential and the calcium equilibrium potential. Now, whenever the question is asking you to answer that equal to equilibrium potential of which ion, so now you have to note down that which tissue they are talking about, neuron. What is the RMP of the neuron? The RMP of the neuron is minus 70, and what ion has an equilibrium potential which is minus 70? That is chloride ion. So, that is why whenever the question is about neuron, then it is the chloride, equal to chloride. And whenever the question is about myocardium, we know that myocardium has an RMP of minus 90 millivolt, and which ion has an equilibrium potential of minus 90 millivolt? That is potassium. So, that is why here if the question is RMP of myocardium is equal to equilibrium potential of which ion, again your answer is potassium. But whenever the RMP of the neuron is equal to equilibrium potential of which ion, then your answer is chloride. So, please do not forget these 4 important lines regarding the RMP, right, because this has been asked multiple times question has been asked from here, and it will be asked in future also. So, please try to remember. Now, the next thing, again another MCQ. So, just now we have understood about the RMP. Now, one applied aspect of the RMP. One clinical scenario has been given. So, again it is a NEET PG question where the potassium level in the blood has been given. Serum potassium level has been given 5.5 milliequivalent per liter. So, this is hyperkalemia. Potassium level is more than 4.5 milliequivalent per liter, that is abnormal, that is higher. So, this is a clear cut case of the hyperkalemia. Okay, hyperkalemia. So, now your question is, in case of hyperkalemia, what will happen to the resting membrane potential, right? So, now you tell me answer. So, whenever you are going to answer this kind of question, what you have to do? You have to first think of that I have a cell here, okay, I have a cell here. This cell has a particular RMP, okay, whatever may be the RMP, but this RMP is mainly due to which ion? This RMP is mainly due to potassium ion, and there will be presence of the potassium leak channel. So, the leak potassium channel is here through which the potassium is leaking out of the cell, because always we know the potassium concentration is high inside the cell. So, whenever the leak potassium channel is present on a cell, the potassium will leak out from the cell. Okay. Now, this leaking out is happening normally. Try to understand, this leaking out is happening normally. Okay. And then leaking out will continue, leak out होते होते एक position आएगा when the outside leaking of potassium will be same to same with the inside leaking of potassium, and that is known as the equilibrium condition. At that equilibrium condition, if you measure the membrane voltage between inside and outside, this membrane voltage will be negative, and that is why we know that RMP will be generated. Now, if there is hyperkalemia, so hyperkalemia means extracellular fluid is having extra potassium which was earlier not there. Now, if the extracellular fluid is containing extra amount of potassium, so what will happen to the movement of this potassium from inside to outside through leakage channel? This movement will be increased or this movement will be decreased? This movement will be decreased because outside potassium concentration is high now. So, because of the increased potassium outside, so what will happen? The more potassium will stay back inside the cell, and because of the staying back of the more potassium, what will happen? The inside will be more and more positive, and this positivity is known as the depolarization. So, in these cases there will be gradual depolarization of the cell membrane. So, if I have to answer in this question, the answer will be more positive. So, in case of hyperkalemia, it will be more positive, and some of you have written decrease. Yes, that is also correct. More positive means whenever the RMP is moving towards the 0 millivolt, that is known as the decrease in RMP, and whenever RMP is going away from the 0 millivolt, that is known as the increase RMP. So, in these cases the RMP will be more positive because potassium leaking will be decreased, and because of the decrease in the leak of the potassium, more potassium will stay back inside the cell, that will causes depolarization. Got it? So, this is the answer, more positive. And the opposite thing will happen if there is hypokalemia question. So, hypokalemia question means the RMP will be more negative, that will be the option number B. Okay. So, now you look at the next, this is not the MCQ, but you have to remember that on the left hand side whatever I have written, this answer you have to do from this question. Now, look at here. So, this is the action potential of the neuron. So, x axis is the time axis, okay, x axis is the time axis, and y axis is the membrane voltage. So, I believe all of you know that this first part of the action potential, this is known as the local potential. After the local potential, the next part is the depolarization phase of the action potential, and after the depolarization, this whole part of the action potential is known as the repolarization, and the part of the repolarization which is going below this resting membrane potential, this is known as the after hyperpolarization. Now, if you look at the ionic membrane, ionic potential, okay. So, if you look at the ionic permeability of this different ion, so sodium ion permeability will follow a curve like this. Sodium ion permeability will follow a curve like this. Okay. So, this is the sodium permeability. This is the sodium permeability, right. So, if you look at the sodium permeability, so look at here. So, sodium permeability is initially very low, and then the sodium permeability is rising to a very high level, and then the sodium permeability is rapidly decreasing. So, from this curve, if you look at this curve, from this curve you have to answer that maximum sodium permeability is happening in which point. So, if I put some different points, so it will be easier for to answer. So, this is suppose point number A, this is suppose point number B, okay. Suppose this mid portion is point number C, then this is the point number D and this is the point number E, right. So, suppose I have given some points. So, the first question, that is the maximum sodium permeability, your answer will be point number B, okay. That is the point number B. So, sodium permeability initially low, followed by increase in sodium permeability along with that of the peak of the depolarization, then rapidly the sodium channel will be inactivated. But if you look at the potassium ion permeability, then potassium permeability will slowly rise and it will peak at the middle point of the repolarization and then it will decrease like this, So, this red color curve, this is the potassium permeability, this is the potassium permeability, okay. So, potassium permeability is maximum at which point? The answer of this question will be point number C. Now, next question, the point where the Vm, that is the membrane voltage, Vm is close to sodium equilibrium potential. So, look at when the action potential is going in the upward direction, when the action potential is going like this, we know that maximum positivity in the action potential appears in and around plus 35 millivolt, Action potential amplitude cannot go beyond that point, plus 35 millivolt, beyond that it cannot go. So, question is at which point the membrane voltage is close to sodium equilibrium potential. So, sodium equilibrium potential, just now you told that this is plus 61 or plus 63 millivolt. So, membrane voltage will never be equal to plus 61 millivolt, but it can go close to that, and close to that means maximum positivity that is happening here in the action potential is point number B. So, again the answer will be point number B here. And if the question is point where the membrane voltage is close to potassium equilibrium potential. So, normally the RMP of the neuron is minus 70 millivolt, but potassium equilibrium potential is minus 90. So, you have to search a point where the membrane voltage is going below the RMP, that is minus 70 millivolt, and the maximum negative point that I can see here is the point number E. So, answer of this question will be point number E, right. So, this kind of image based question has already been given in NEET entrance examination. So, please be prepared for this, okay. And I believe all of you know that the depolarization phase is due to the sodium ions and the repolarization phase is due to the potassium exit from the cell. All of you know this thing. So, I am not going to discuss that, okay. So, that is very simple. So, this is about the action potential. Now, after this action potential, one important table is given in front of you. So, obviously, you have to memorize this information from this table, but at least I will tell you that this nerve fiber classification that has been given here. So, we all know that A type fiber, B type fiber and C type fiber. Among this A, B, C, A and B fiber, they are the myelinated fiber, A fiber and B fiber, and C fiber are the unmyelinated fiber. Now, all of you know that if you go from the myelinated fibers towards the unmyelinated fibers, so what will happen to your conduction velocity? The conduction velocity will decrease. So, if you go in that direction, so there will be decrease in the conduction velocity, and same for the diameter of the neuron will also decrease in this direction, that you all know, right. Yeah, I am Bengali. So, what is the problem? हाँ, yes, okay. चलो यहाँ पे देखो chatting में लग गया. Okay, so look at here. So, this A fiber, B fiber and C fiber classification, this classification was given by Erlanger and Grasser, and followed by this numerical classification was given by Lloyd and Hunt. ये दोनों scientists दिया था. So, देखो you have to remember parallelly both of these things, because sometimes they will ask you question that one A fiber has a conduction velocity of, because one A fiber is the afferent from the muscle spindle. It is a very common question. So, they will ask you a question that one A fiber has a conduction velocity of. So, A alpha type of fiber is same with that of the 1A and 1B, which has a conduction velocity of highest conduction velocity in our body, that is 70 to 120 meter per second. Getting my point? Okay. So, at least you try to remember the conduction velocity of the first two types of fiber, A alpha and A beta. बाकी का आप भूल भी जाओ, I will not mind, but first two conduction velocity you have to remember. Then you try to remember this important column, this is the most important thing that you have to remember, that which type of fiber is present in which location, which type of fiber is present in which location. This is the functions or location. So, the first A alpha is present in the proprioceptive fiber and the motor neuron, they are the A alpha type of fiber. Then pressure and touch, they are the A beta type of fiber. Muscle spindle, the efferent to the muscle spindle is A gamma fiber, and A delta fiber there for the pain and temperature, temperature or pain, and pain and temperature is also carried by C type of fiber, as you can see here. But C type of fiber is the unmyelinated fiber and A delta type of fiber is a myelinated fiber. So, that is why the pain which is carried by this A delta fiber, this is known as the fast pain or the first pain, and the temperature which is carried by the C fiber is the warm temperature, and the temperature which is carried by the A delta fiber, this is the cold temperature. So, this difference you also have to remember, that pain and temperature is carried by both of this type of fiber. Okay. So, sometimes some mnemonics can be framed here. So, that Prime Minister pressurizes to sign the peace agreement, So, this way you can make a mnemonics also to remember all of these things, but I am telling you all these locations of this fiber is very, very important to be remember. Okay. And apart from this table, you have to remember that just now we discussed that the cold sensation is carried by A delta fiber, warm sensation, burning pain, freezing pain, all are carried by the C type of fiber. Okay. And then this inherent question, all of you know that local anesthesia, which fiber is most sensitive. So, according to anesthesia we are following this, the A gamma is the most sensitive, followed by A delta, uske baad A alpha, A beta, followed by B, followed by C, right. And in pressure the most sensitive fiber is the A fiber, followed by B fiber, followed by C fiber. Okay. And in hypoxia the most sensitive fiber is B, followed by A, followed by C. And sometimes the spike duration can also be asked. So, the spike duration means it is a part of the action potential which is known as the spike potential. Okay. So, slower the conduction velocity, more will be the spike duration. So, that is why the C fiber followed by B fiber followed by A fiber. So, these are the memory based questions, but they give you this kind of question. So, please try to remember this memory based question. Gate control theory, generally gate control theory I teach in INI-CET type of exam. For NEET PG I have not included today. Okay. You have to look at other sources. So, now after discussing these different types of fiber, the DHPR RYR coupling, this is a recent important topic when the INI-CET as well as the NEET PG they are asking question from this topic. So, we are going to discuss that how this DHPR and RYR coupling is happening in case of skeletal muscle as well as in case of cardiac muscle. There is a difference, two terms are different. So, you have to understand the mechanism. So, look at what is this. So, this is the membrane, cell membrane or the skeletal muscle membrane, and it is forming a T tubule, it is forming a T tubule, right. So, this T tubule contain a channel. So, this T tubule contain a channel which is known as the DHPR channel, DHPR channel. Very good, very good. All of you are answering. So, all of you have read it, very good. So, near to this T tubule, this sarcoplasmic reticulum will be there, and inside this sarcoplasmic reticulum calcium is there, and on the membrane of this sarcoplasmic reticulum the channel which is present for the release of calcium is the RYR type of channel. Okay. RYR type of channel. So, what happens basically, the DHPR whenever it is activated, so suppose there is an action potential here, so this action potential will causes depolarization, okay, depolarization. So, this depolarization will first stimulate this DHPR channel, and this DHPR channel will be activated. After activation, this DHPR channel will interact with RYR channel, and this interaction is a mechanical interaction, physical interaction. What happens basically, you know, this DHPR channel, suppose this is DHPR and this is RYR. So, what happens, this DHPR first it will be activated. How? Whenever the action potential is there on the muscle membrane, and whenever this DHPR is activated, the conformation of this protein, DHPR protein channel will be changed, and because of this conformation and change, it will causes interaction with the RYR, and then it will causes twisting movement of the RYR, and because of the twisting mechanical movement of the RYR channel, the channel will open up, and because of the opening of the RYR channel, what happens, the calcium channel will open up, this RYR channel will open up, and through this RYR channel the calcium is going to enter in the cytoplasm, and then this calcium is going to causes contraction of the muscle. So, two important things you have to remember here, that in case of skeletal muscle, look at here, in case of skeletal muscle, the all of the sources of calcium, 100% source of calcium for muscle contraction is coming from which organelle? Is coming from the sarcoplasmic reticulum. And how this calcium release is happening? This calcium release is happening because of the interaction of the DHPR and ROIR, and this type of interaction where the DHPR is physically interacting with the ROIR channel, this kind of interaction is known as the mechanical interaction. That is why we say that the coupling between DHPR and ROIR is the mechanical coupling. So, you have to remember that in case of skeletal muscle, the coupling is the mechanical coupling, and this mechanical coupling will happen in presence of electrical activity, that is action potential is the electrical activity. So, in presence of electrical activity this will happen. So, electromechanical coupling is the better answer, but if the electromechanical word is not there, then mechanical option has to be chosen, right. So, in the MCQ that is the you have to follow. Okay. Now, if you look at the cardiac muscle, so in cardiac muscle similar kind of channel will be there, the DHPR. Okay. So, the DHPR channel is there, and just near to this DHPR this sarcoplasmic reticulum will be there. So, the sarcoplasmic reticulum will contain ROIR. Okay. Similar kind of channel, different variety of ROIR. So, this is ROIR2 basically. Okay. But in case of cardiac muscle, whenever the action potential is reaching on the surface of this membrane, this action potential, okay, will first stimulate this DHPR channel here. Okay. But in these cases, yes, you know, so in these cases the DHPR channel is not going to interact with the ROIR channel mechanically. No, they too, the DHPR and ROIR, they will not interact mechanically, but rather this DHPR channel will open up, and because of the opening of the DHPR channel, calcium ion will enter in the cytoplasm. Where from this calcium is coming? This calcium is coming from the extracellular fluid. So, please remember that extracellular fluid is going to enter in the muscle cytoplasm first in cardiac muscle. That extracellular calcium is very little, but this little amount of calcium is going to causes stimulation of this ROIR channel, because in case of cardiac muscle this ROIR channel is known as the calcium induced calcium channel. Yes, calcium induced calcium channel. So, whenever little amount of calcium is entering in the cytoplasm, this little amount of calcium, what it is going to do? It is going to stimulate the ROIR channel, and whenever the ROIR channel is open up, so further calcium is going to enter from sarcoplasmic reticulum. So, this calcium, now the sarcoplasmic calcium is entering in the cytoplasm. So, now the calcium which has entered from the ECF and the calcium which has entered from the sarcoplasmic reticulum, combination of both of this calcium is going to causes contraction of the cardiac muscle. But here I can find out that there is no interaction, though no mechanical interaction between DHPR and ROIR, they are separated. Okay. But the only connecting link between this DHPR and ROIR is done by this calcium ion. So, calcium ion being a chemical, we name this type of coupling as a chemical coupling. So, that is why we say that in case of cardiac muscle the chemical coupling happens, and obviously you require an electrical activity of the cell membrane, and then only the chemical coupling is going to happen, but this is known as the electrochemical coupling. Okay. Now, this electrochemical coupling is also known as CICR. CICR full form is the calcium induced calcium release. Okay. So, already you have written. Okay. So, this is known as the calcium induced calcium release. What is that? So, outside calcium is entering, and that outside calcium is inducing the further release of calcium from sarcoplasmic reticulum. This is known as the calcium induced calcium release. Got it? So, this electrochemical coupling is also known as the calcium induced calcium release. Fine. So, this coupling reaction is very, very important. Now, you look at another MCQ from the neurophysiology, the somatosensory receptor, the somatosensory receptor. So, what will be the answer of this question? So, select the correct option regarding the function of this receptor. So, Ruffini's corpuscles, this is basically activated in presence of stretch on the skin. Ruffini's के लिए stretch is the stimulus. Merkel cells के लिए any kind of point source is the stimulus or edges, these are the stimulus. For Meissner corpuscles, okay, slow vibration is a stimulus for the Meissner corpuscles, okay, and Pacinian corpuscles, first vibration is a stimulus. So, vibration frequency should be 200 Hz or more, that is the first vibration. So, Pacinian corpuscle is for first vibration, this is completely matching, the other is not matching, because I told you already that for Ruffini's the best one is the stretch, for Meissner the slow vibration, for Merkel's point is the main important stimulus. So, answer of this question is option number D. Now, you take a quick revision. So, tactile receptor or the touch pressure receptor, they are classified into rapidly adapting and slow adapting receptor. So, under rapidly adapting, Pacinian, Meissner's and hearing organ, you have to first recall this name also, first recall this name, and then you remember that this Pacinian corpuscle, this is best for, just now we have discussed that it is for vibration, first vibration sense, okay, high frequency vibration, and second one is for the deep pressure. Both of these has been asked in NEET and INI-CET examination to try to recall them. Okay. So, Pacinian corpuscle is for first vibration and the deep pressure, and this is the most sensitive tactile receptor in our body. Okay. Then coming here the Meissner corpuscles. I say that Meissner corpuscle, they are exclusively present in the hairless skin, the glabrous skin. Okay. And whenever anything is moving on this glabrous skin, anything is moving, so moving touch is the best stimulus for the, so any kind of touch which is moving on your surface. So, moving touch I am writing here, that is the most important. Okay. So, this is equally important for both of the INI-CET and NEET. Okay. INI-CET, NEET, how much questions are different? In now, in recent time, the most of the questions in the INI-CET and the NEET are same, almost same to same. Okay. So, this is equally benefit for how to remember by revising. So, the best way to remember is revise. Okay. मैंने इतना सारा क्लास ले लिया अभी तक, इतना साल हो गया, तब भी मैं भूल जाता हूँ. सो आपका वट एवर यू आर फॉरगेटिंग ना, दैट्स अ नॉर्मल वेरी नेचुरल फिनोमेना. इट्स नहीं कि आप जब वो पढ़ोगे सब कुछ याद रह जाएगा. सो रिविजन करना होगा आपको. ओके. सो Meissner corpuscles moving touch is the most important stimulus. Apart from that, just now we have discussed that the slow vibration, vibration frequency in and around the 50 Hz is important here. And I told you here the first vibration in and around 200 Hz or more is the for the Pacinian. And hair end organ, again anything which is bending your hair. Okay. So, hair end organ obviously it will be present on the hair skin, and whenever this hair follicle is bending due to any reason. So, that is why it is written in Guyton that whenever any object is first time touching your skin. So, remember this line, because sometimes the questions will be lifted directly from the lines in Guyton and Ginong. So, whenever any object is touching your skin from the first time, the hair skin, that touch is first detected by this hair end organ. So, that is why we say that any kind of hair movement, so any kind of first touch, okay, on surface of the skin, obviously that skin has to be hairy skin, that is detected by this hair end organ. Okay. And then on the slowly adapting receptor, Merkel's disc is there, Meissner's is there, and free nerve ending is there. So, Merkel's, I told you that this is for perception of point. Okay. So, 2 point discrimination, जो concept है 2 point discrimination, that is by this Merkel's. Okay. So, Merkel's is for the detection of the point, okay, any corner, okay, edges, all these are the stimulus for the Merkel's. So, if I want to perceive the edges of this table, so that is also detected by these Merkel's. Any kind of sharp point, so this point tip of the pen is touching my fingertip. So, I am feeling that there is a single point. So, this point perception is also by this Merkel's, and I believe you know that Merkel's is the receptor for 2 point discrimination as well as reading of Braille. Both of them, Braille reading as well as 2 point discrimination, for both of them Merkel's is the best receptor, although Braille reading also required the help of Meissner's. It is a controversial one, I know, but here I am not going to trap into your controversy. Whatever I am saying, want to follow it well and okay, follow it, otherwise you go into the controversy and waste your time. It is your choice, but for both the cases the answer for Braille reading as well as 2 point discrimination, the answer is Merkel's. Okay, answer is Merkel's. Now coming to the Meissner corpuscles. Okay. So, oh sorry, so Markels, so here you must have noted here, so Markels यहाँ पे रूफिनीज आएगा, ओके, सो रूफिनीज बिकॉज बोथ साइड में आपका मार्केल्स आ गया, रूफिनीज कॉर्पसल्स, ओके, एंड द रूफिनीज कॉर्पसल वी हैव ऑलरेडी डिस्कस दैट एनी काइंड ऑफ स्ट्रेच ऑन स्किन, any kind of stretch on skin is detected by Ruffini's corpuscles or Ruffini's organ. So Ruffini's क्या होता है कि suppose you place some large object on the surface of your hand, okay, so it will cause a stretch on the skin. That stretch is best detected by this Ruffini's organ, okay. So Ruffini's is for the stretch on the skin and free nerve ending for itching and tickling, itching and tickling. So tickling and itching, they are detected by free nerve ending, okay. I told that Braille for Braille, okay, Markels greater than Meissner's, Markels greater than Meissner's, okay. So remember this, okay. So tickling and itching is by free nerve ending, okay. Now go to the next question. So here a long clinical question has been given. Woman is suffered from the sunburn, okay. Try to answer this question. उसके बाद the woman is taking a bath in lukewarm water. So if the temperature is 40 degrees centigrade, then which receptor will be activated? First you answer this, that thermoreceptor will be activated or nociceptor will be activated, okay. So thermal nociceptor or normal normal thermoreceptor, which will be activated? So we know that there are cold receptor present in our body which is active from 10 degrees centigrade to 40 degrees centigrade temperature, and there are warm receptor in our body, they are active from the 30 degrees centigrade to 49 degrees centigrade. This has also been asked in the NEET entrance examination. So NEET and NEET PG दोनों के लिए important है. So cold and warm, they are known as the thermoreceptor. So they are known as the thermoreceptor. But whenever the temperature is going beyond this range, means if the temperature is greater than 49 degrees centigrade, in these cases rather than thermal receptor, nociceptor will be activated, and this kind of nociceptor are known as the thermal nociceptor. Getting my point? Thermal nociceptor. Nociceptor can be activated by mechanical, thermal, chemical stimuli. So the nociceptor which are activated by high temperature greater than 49 degrees centigrade, they are known as the thermal nociceptor. So whenever the person is taking a bath in lukewarm water which is a temperature of 40 degrees centigrade, इसमें क्या फीलिंग होनी चाहिए था? पेन होना चाहिए था ना? पेन क्यों होगा? क्योंकि इट विल एक्टिवेट द थर्मोरिसेप्टर. सो इसमें हॉट फीलिंग होना चाहिए था, बट दैट हॉट फीलिंग इज नॉट देयर. सो इफ आई हैव टू थिंक दैट थर्मल नॉसिसेप्टर एंड नॉसिसेप्टिव पेन, सो इज इट ए नॉसिसेप्टिव पेन? इज इट ए स्टिमुलस फॉर द नॉसिसेप्टर? इज इट ए स्टिमुलस फॉर द नॉसिसेप्टर? आंसर इज नो. सो दिस कैनॉट बी माई आंसर. सेकेंड वन, थर्मल नॉसिसेप्टर एंड एलोडाइनिया. एलोडाइनिया तो बाद में आएगा, बट will the thermal nociceptor will be activated at 40 degrees centigrade temperature? Answer is no. So again the option B cannot be the answer. So obviously the answer will be between C and D. So innocuous thermal receptor, obviously the 40 degrees centigrade temperature will activate the innocuous thermal receptor. Otherwise India में तो सब पेन ही पेन हो जाएगा पूरा बॉडी में. अभी तो 40 डिग्री चल रहा है दिल्ली में. So they are going to activate the thermal receptor. They are innocuous. Innocuous means they are not supposed to give you the pain perception. But here the symptoms has been given that in 40 degrees centigrade the person is feeling pain, the woman is feeling pain. So now innocuous thermal receptor is activated, but 40 degrees centigrade normal temperature is giving you pain sensation, that is known as allodynia. Allodynia. So the answer of this question will be option number D, that in this cases the innocuous thermal receptor will be activated at 40 degrees centigrade warm water, and this innocuous thermal receptor activation हो रहा है, but what you are feeling pain. So this is not a normal feeling, this is abnormal feeling. What kind of abnormal feeling? This is known as the allodynia. So what is the difference between this hyperalgesia and allodynia? So look at here, the hyperalgesia is exaggerated response to a noxious stimulus, meaning the stimulus which is supposed to give you pain sensation. Suppose if I am giving like this, so this is a mechanical stimulus. So in this stimulus if I give like this, so you are supposed to get pain, but you are getting exaggerated pain response. मैंने ऐसे करके मारा आपने, oh my god, severe pain. So that's an exaggerated response, that is hyperalgesia. But I am giving you touch sensation and you are feeling it pain, then that is not supposed to give you the pain sensation. So this sensation is not going to give you the pain, but you are feeling it as a pain. So that is known as the allodynia. So that's why it is said that allodynia means the sensation of pain in response to normally innocuous stimulus. So that's why we have chosen the answer number D in the previous question, that 40 degree centigrade temperature is an innocuous stimulus for our body, but if a person is feeling pain, so that is allodynia. Getting my point? So this is the thing that you have to remember. Okay, very good. Understood everybody? Okay. Now the next one is the muscle spindle and Golgi tendon organ. So this Golgi tendon organ, this is located in the tendon muscle junction. Okay. So this is located in the tendon muscle junction, and what is the stimulus for this? Increased tension at the level of tendon. Increased tension at the level of tendon is a stimulus for this. Okay. So Golgi tendon organ, ये दो चीज़ ध्यान रखो. उसके बाद आ जाओ ये जो न्यूक्लियर बैग फाइबर एंड न्यूक्लियर चेन फाइबर. So these are the two types of fiber, they are present in muscle spindle. All of you know that. So the muscle spindle contain nuclear bag fiber and nuclear chain fiber. Now this nuclear bag fiber are of two types. One is the dynamic bag fiber and one is the static bag fiber. Tell me the answer. Dynamic bag fiber, they detect which sensation of the muscle, which parameter of the muscles. Okay, everybody write your answer. Dynamic bag fiber, it was been asked in INI-CET and NEET PG both. And nuclear chain fiber, they are always static in nature. Okay, very good, very good. I got the first answer. Velocity, very good. No. So length upon time is detected by dynamic fiber. So please remember, this dynamic fiber detect the velocity of muscle. So what is velocity? Velocity is length upon time. So this length upon time is detected by dynamic fiber, and static fiber, they only detect the increased length of the muscle. They only detect the increased length of the muscles. Getting my point? So this diagram, it is a muscle spindle. So muscle spindle contain this center fiber. This center fiber is known as the nuclear bag fiber, because it's a bag like area is present here. So this is nuclear bag fiber. Okay, and from the nuclear bag fiber and chain fiber, there is one afferent. This afferent is 1A type of afferent. And from the peripheral part of this muscle spindle, there is another afferent which is known as the type 2 afferent. Okay, and the afferent from this Golgi tendon organ, this is 1B afferent. Now all of you tell me, if I ask you this 1B afferent, 1A afferent, are they myelinated or unmyelinated? Write down M or U, so that I can understand that you are following. So 1A fiber or 1B fiber, both of them are myelinated, or one of them are myelinated, unmyelinated? What is your answer? Okay. So just now we have seen one classification of the nerve fiber classification. So this 1A and 1B, very good. The 1A and 1B, they are basically 1-alpha type of fiber, and both of them are myelinated fiber, and conduction velocity is now 70 to 120 meter per second. Got it? And this muscle spindle will have one efferent. Next question. The muscle spindle will have one efferent. So that efferent will supply the terminal part of the muscle spindle. What is the name of this efferent? What is the name of this efferent? So this is efferent to muscle spindle. Which nerve fiber is the efferent to muscle spindle? Could you recall? Could you recall? Yes, everybody. Is that myelinated or non-myelinated? A alpha is not the muscle spindle. Muscle spindle are the intrafusal fiber. A alpha is the extrafusal fiber supply to the muscles. A alpha is known as the motor neuron. What is the meaning of motor neuron? Motor neuron supply the muscles, but this muscle spindle is the muscle receptor. It is not the muscle contraction per se. So this is the muscle receptor. So the efferent for this muscle spindle is A gamma fiber. Okay, and A gamma stimulation means the muscle spindle will be increased sensitive. Okay, so please remember that the afferent from this डायनामिक बैग फाइबर, स्टैटिक बैग फाइबर एज वेल एज स्टैटिक चेन फाइबर, तीनों जगह से जो आफरेंट ऑरिजिन होता है दैट इज 1A टाइप ऑफ आफरेंट, 1A टाइप ऑफ आफरेंट. एंड ये जो टाइप 2 आफरेंट है, type 2 afferent will originate only from this static chain and static bag fiber, static chain and static bag fiber from type 2 afferent. Okay, so type 2 means always that is the static fiber को connect कर रहे हैं, and 1A fiber जो है ये dynamic static दोनों को ही connect कर रहे हैं. Now if I ask you a question, this kind of question has been asked in INI-CET and Eureka, that 1A fiber is activated by velocity of the muscle, by increased length of the muscle, both of the above, none of the above. So what will be the answer? A, B, C, D. So 1A fiber is activated due to change in the length of the muscle. Option B, velocity of the muscle. Option C, both of the above. Option D, none of the above. So what will be the answer in this question? The answer will be both of the above, because 1A fiber is connecting this, okay. So this dynamic fiber also as well as this static fiber also, okay. So please try to revise this thing once again by downloading the PDF. I will share the annotated PDF, it will be available in the PrepLadder app, okay. So please revise, because these are the most important topic. आप INI-CET बोलो, आप NEET PG बोलो, कोई भी एग्जाम के लिए, ठीक है. अब आ जाओ ascending tract. So ascending tracts of the spinal cord, you know कि what are the different ascending tracts, but for physiologists, okay, you have to remember that which tracts carries which sensation. That should be on your fingertips, and you should not forget this. So posterior column or the dorsal column, localizing pressure, vibration, fine touch, proprioception, 2-point discrimination. Okay, that is the posterior column or dorsal column. Anterior column is the crude touch, pressure, tickling, itching and sexual sensation, and the lateral column is for pain and temperature. I am not going to give much of the time here, because you know from anatomy also and physiology also, but just try to revise this thing, okay. And then we are coming to the basal ganglia and cerebellum. Very simple topic, okay, but sometimes we do mistake, okay, from the very simple topic also, basal ganglia and cerebellum also. So at least you have to remember what is the functions of basal ganglia and cerebellum. So basal ganglia main function is for motor planning and programming, but not the smoothing of movement. So sometimes there is a question that smoothing of movement में एक गड़बड़ हो जाता है. So smoothing and coordination of this movement is done by the cerebellum. So please try to remember, प्लानिंग एंड प्रोग्रामिंग में दोनों का ही रोल है. बेसल गैंग्लिया, सेरिबेलम दोनों का ही रोल प्लानिंग एंड प्रोग्रामिंग में है. यहाँ पे देखो ये जो सेरिब्रो सेरिबेलम लिखा है, दिस इज सिमिलर टू द बेसल गैंग्लिया फंक्शन, मोटर लर्निंग एंड प्लानिंग. सो आई एम राइटिंग हियर, दिखाई देगा? नहीं दिखाई देगा. सो यहाँ पे लिखता है. सो ये जो सेरिब्रो सेरिबेलम, जिसको हम लोग लेटरल सेरिबेलम बोलते हैं, दिस इज ऑल्सो रिस्पॉन्सिबल फॉर प्लानिंग एंड प्रोग्रामिंग. दिस फंक्शन इज सिमिलर टू बेसल गैंग्लिया, बट smoothing and coordination of the movement is done by the cerebellum. Which part of the cerebellum? The spinocerebellum. And vestibulocerebellum is for balance and posture. Okay. एंड दोनों का ही बेसल गैंग्लिया एंड सेरिबेलम दोनों का ही कॉग्निटिव फंक्शन में रोल है. सो इसीलिए देखो कॉग्निटिव फंक्शंस दोनों में बेसल गैंग्लिया सेरिबेलम दोनों का ही functions होता है. Okay, so this way you try to compare these two functions and remember these two functions. So basal ganglia main function is planning and programming. Same is also done by cerebellum, but lateral cerebellum or the cerebrocerebellum. But cerebellum has an additional function, that is smoothing and coordination of the movement. So when the movement is going on, generally cerebellum function test करने के लिए हम लोग क्या बोलते हैं कि you bring your finger from a distance and you try to touch the tip of the nose, ऐसे हम लोग बोलते हैं. So this is long distance traveling of this hand. So during this long distance traveling, I have to constantly give feedback to the cerebellum, and based on that feedback, the cerebellum will cause a smooth movement of this thing. Okay, but whenever the cerebellar lesion is there, this smooth movement is not going to happen. The cerebellar disease patient will touch like this. Okay, so that is the thing which is known as the smoothing and coordination of the movement. Whenever the movement is happening a long distance, during the movement also the cerebellum has to give some correction, and that is smoothing and coordination. Now after understanding the functions, this is the must know thing. It has been asked in the NEET PG also, and obviously it will be asked in the INI-CET also. So basal ganglia disorder, so hypokinetic disorder, अंडर दिस हाइपोकाइनेटिक पार्किंसनिज्म, बट यहाँ पे लिखा है कि हाइपर काइनेटिक फीचर भी होता है, क्योंकि हम लोग जानते हैं कि इसमें जो ट्रेमर होता है, सो पार्किंसनिज्म डिजीज में जो ट्रेमर होता है एंड जो रिजिडिटी होता है, ओके, सो these two are the hyperkinetic feature, and the main feature जो akinesia or bradykinesia जो होता है, that is the hypokinetic feature in the Parkinsonism disease. Okay, so the main is the bradykinesia or hypokinesia, so that's why it has been put in the hypokinetic. And in hyperkinetic disorder, you have to recall this thing that hemibalismus is due to subthalamic nucleus problem, the Huntington's is due to striatum indirect pathway problem, and the dystonia is due to direct pathway disorder. Okay, so these are the basal ganglia disorder, and now you remember the cerebellar lesion, cerebellar disorder. So cerebellar disorder means the features that you have to remember like this: Danish, D-A-N-I-S-H, D-A-N-I-S-H, Danish. So D stands for dysdiadochokinesia. You all know that rapid alternation, supination, pronation, dysmetria, past pointing. Okay, so whenever you ask to bring this thing, it will be it will not touch the point, it will past pointing, and decomposition of the movement. Decomposition means ये जो smooth movement is going on ना, the every joint is taking part in this movement, but whenever there is decomposition, each and every joint will move in a different way. So that is known as the decomposition movement, and there will be delay in initiation. Danish bhai. Okay. So now second one is the ataxia, nystagmus, intention tremor. I believe you know from your medicine knowledge that the tremor which happens in cerebellar lesion is the intention tremor. Means whenever you want to pick up something or you want to do something, that time the tremor will appear. But in case of Parkinsonism, the gross resting tremor will be seen. So Parkinsonism, this tremor is the resting tremor, and here the tremor is the intention tremor. And one most important thing that you have to remember here, that in case of cerebellar lesion, there will be hypotonia. Hypotonia will be there. It has been asked in questions already. Okay, so try to remember the cerebellar lesion features. And then one of the important question which has been asked in a single liner question, that which nucleus of hypothalamus is doing which functions. So here you remember that anterior nucleus as well as the posterior nucleus both are responsible for thermoregulation, but they have asked you direct question in INI-CET that which of the following is the severing center. So the severing center is the center of the hypothalamus which responds to cold, which responded to cold. Okay. So whenever you are exposed to cold environment, the nucleus which is going to respond in this cold environment, that is known as the center for severing. And what is that center? That is the posterior nucleus of hypothalamus. So the posterior nucleus of hypothalamus is going to give you response in cold environment, and anterior nucleus of hypothalamus is going to activate in hot response. So anterior nucleus for hot and posterior nucleus is for cold. Okay. So this is first. Then suprachiasmatic nucleus, all of you know that the suprachiasmatic nucleus is responsible for maintaining a biological rhythm which has exactly duration of 24 hours, like for example ACTH, okay, secretion, the cortisol secretion, all of them follow a 24-hour cyclicity. This 24-hour cyclicity is basically your circadian rhythm, and there is a question in INI-CET that if there is destruction of this suprachiasmatic nucleus, what will happen to the, so whenever there is destruction of this suprachiasmatic nucleus, the circadian rhythm duration will be greater than 24 hours, greater than 24 hours. So this answer you have to also have to remember. Okay. And then the lateral nucleus of the hypothalamus is for the thirst and hunger. Okay. And again the INI-CET question has been asked, the medial forebrain bundle reward center and periaqueductal gray matter punishment center. This is the most important thing, and osmoreceptor also they has been asked multiple times. So anterior nucleus also contain osmoreceptor. So just try to remember this thing. Anterior, okay, no problem, no comment from here. So hypothalamic nucleus. Now you try to answer this question. This is a NEET question last year. Okay, which tongue papilla does not have taste bud? So we have circumvallate papilla, it has taste bud. Okay, foliate papilla, it also has. Okay, fungiform, it also has taste bud, but the filiform papilla has no taste bud. So if you look at the question, NEET PG is asking some questions are very simple and some questions are very difficult. Okay, this type of questions they are asking nowadays, and mostly the questions are almost similar with that of the INI-CET and NEET. Okay, in my subject I can tell you. Okay, so answer of this question is D. Okay, now another question in the same exam, another question from the test sensation. Okay, so generally smell and taste हम लोग छोड़ के जाते हैं physiology में, but last time they have asked two question in NEET PG. So the question is savor taste is mediated by which of the following? So answer of this question is option number D. I will tell you why, because explanation you have to remember. Okay. So, now look at here TRPP3, this is the answer of this question, look at here. So, this slide, okay, you try to remember, because nowadays they are asking certain questions which are difficult, and these are the type of question they are asking. So, we know that 5 different primary tests are there. So, we classify the test into their receptor. Some of the test sensation as ionotropic receptor. What is the meaning? Meaning the receptor is a ion channel in these cases. So, the chemical molecule will be attached with this receptor, and this receptor will behave like an ion channel, so ion will enter through this receptor. That is the meaning of the ionotropic receptor. And some of the test receptor, they are metabotropic receptor, means if this is the cell membrane, so the receptor will be present here, onto this receptor the chemical is going to be attached, and after attachment of this chemical, the receptor is going to stimulate the G protein. So, metabotropic receptor means they are basically the G protein coupled receptor, that is why it is written here, this is GPCR. So, metabotropic receptor, they are the GPCR. Now, this GPCR is a big family member of receptor. GPCR is a big family member of receptor. It has T1 receptor family also, it has T2 receptor family also. So, that is why you have to remember separately that for umami taste sensation, which family is activated, for bitter and for sweet, which are the receptor activated. So, for umami taste sensation, I believe you know that umami is the taste of the monosodium glutamate, as you know what jisko bolte ho. So, that is T1R1 and T1R3. So, at least you remember that T1 family of the receptor is activated in umami taste receptor. So, umami, that is a monosodium glutamate salt, right. So, they will activate T1 receptor family. Bitter taste will activate T2 receptor family, and sweet taste will activate T1 receptor family. At least you remember this T1 or T2 family. Okay. T1, R3, R2, that is a more deeper one, but at least you remember. And if you look at the ionotropic receptor, salt sensation is detected by INI-CET channel. So, INI-CET channel we have read in different area, that is in the renal system we mainly read, also it is present in the GIT. So, this is also present at the level of the taste receptor. Okay. So, the INI-CET channel is the for the salt sensation, and for this H plus ion detection, that is the shower test. H plus ion detection is done by this TRPP3. TRP stands for transient receptor potential, transient receptor potential family, transient receptor potential ion channel family, P3 subvariety. H plus ion can also be detected by HCN channel, that you all know in the cardiovascular system, the nodal tissue contain the HCN channel, the hyperpolance induced CMP nucleotide gated channel, and ASIC. ASIC stands for acid sensing ion channels, acid sensing ion channels. So, all these channel can detect sour test. Okay. So, try to remember this slide. Okay. Just mog up this information. Okay. Now, the neurophysiology is done. Now, we are going to enter into the other part. This neurophysiology is the maximum one in this session. Okay. And followed by cardiovascular, followed by renal, followed by respiratory, ऐसे करके मैंने रखा. So, now look at the general physiology. So, general physiology, the first thing, all of you know this thing, that total body water is 60% of the body weight, and this total body water is distributed into ICF, which is 40% of the body weight, and this is 20% of the body weight. So, we all know that ICF is the 2/3 of the total body water, 2/3 of the total body water, and ECF is equal to 1/3 of the total body water. Then you all know that this interstitial fluid is 15% of the body weight, and plasma is 5% body weight. But apart from this, the most important is that how this body fluid is measured. So, see here, to measure the different body fluid compartments, suppose I want to measure what is the total body water inside my body. So, I have to use one substances to measure this body water. Okay. So, what is that substances? The deuterium oxide, the tritium oxide, the antipyrine. These are the 3 substances name that you have to remember. I am telling you, this is one of the important slide that you have to remember. Okay. Then ECF volume, extracellular fluid volume, can be measured by inulin, sucrose, sodium, iodine isotope, and mannitol. Okay. And then ICF, the intracellular fluid volume, it cannot be measured directly. You have to measure the total body water, and you have to measure the ECF, means you require 2 substances, one from here, one from here. Okay. Then plasma volume, it has been asked in the exam. The Evans blue is used for measuring the plasma volume, and albumin tagged with iodine. that can also be used for measuring plasma volume. Interstitial fluid also cannot be measured from the substances directly. You have to measure the extracellular fluid volume first, and you have to measure the plasma volume, and you subtract, then you are going to get the interstitial fluid volume. Okay, right. And then RBC volume you can also measure. Now look at here, the blood volume measurement formula. One blood volume measurement formula is written here. This is plasma volume upon your 1 minus hematocrit volume. Plasma volume upon your 1 minus hematocrit volume. You also try to remember this formula, because I have seen one question where they have given you that what is the normal plasma volume of the person, what is the hematocrit of the person, suppose 45%. So 1 minus 0.45 will be placed here, and you calculate what is the blood volume of that person. Getting my point? So if the hematocrit is given as 40%, then you have to put here 0.4. That is the way you can calculate the blood volume of the person. So all of these substances, they will be used to measure different fluid volume compartment, and you have to remember these different substances, that for plasma, for RBC, what substances is used, and the formula which is used to calculate the volume of the different compartment. So volume will be equal to Q minus E upon C. Okay. So suppose I have used this deuterium oxide, I have injected in the body. So what is the total amount of deuterium oxide that I have injected, that I have to look at, that is the total quantity which I have injected. And then after injection, how much amount of deuterium oxide is excreted from my body. So this E stands for excretion. And after the steady state distribution, what is the final concentration of the deuterium oxide in my blood? If you put these three parameters, then you are going to get what is the total body water in my body. So this formula is used to calculate different body fluid. This is known as the volume of distribution formula or dye dilution formula. Okay. So this is and this is the dilution formula, the volume of distribution formula. Okay. So this formula is used to measure the different fluid volume in the body. Okay. Very good. Okay. So now this is done. Now the next thing is the different types of transport. Now why these different types of transport is important? First you try to look at these MCQs. So tell me the answer, I am waiting. NEET PG question again. Okay, yes. So why it is facilitated diffusion, not that secondary active transport or primary active transport? Because here if you look at the number of molecule here, so huge number of molecule here means this is the high concentration. So the molecule is moving from high concentration to low concentration. So whenever the molecule is moving from high concentration to low concentration with the help of a carrier protein, this kind of transport is known as the facilitated diffusion. This kind of transport is known as the facilitated diffusion. Getting my point? So please try to remember. So try to remember here that type of transport, primary active transport and secondary active transport. Okay. So secondary active transport, any kind of symporter, any kind of antiporter, they are the secondary active transport. The example of this symporter like SGLT, so the glucose transporter SGLT, they are the symporter. Okay. And that is secondary active transport. Antiporter like NCX, sodium calcium exchanger, they are also antiporter, they are antiporter. So they are also secondary active transport. And any molecule which is attached with this name ATPase, 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 they will be known as the primary active transport. Now just now I told you that the example, the question that has been given here, that is a facilitated diffusion. So the facilitated diffusion and the simple diffusion, ये दोनों के बीच में difference is that in the facilitated diffusion the carrier protein molecule will be there, but in simple diffusion the carrier protein molecule will not be there. So the carrier protein molecule is also required for the secondary transport also and primary active transport also. So you have to remember that carrier protein means, look at this diagram. So carrier protein is required for the facilitated diffusion also as well as for active transport also. But the difference is that in case of active transport, the requirement of adenosine triphosphate is there. So active transport means adenosine triphosphate is there, but requirement of ATP will not be there in case of facilitated diffusion. And the second thing is that in active transport, the movement will happen from low concentration to high concentration. The movement of the substances will happen from low to high concentration. Same for here also, that from low concentration the substances will move to high concentration, that is the active transport. But for facilitated diffusion, it will move from high concentration to low concentration, that we have just seen, and carrier protein is required, but high to low concentration में हो रहा है and adenosine triphosphate का जरूरी नहीं है, that is your facilitated diffusion. Now please try to clear one confusion here. Suppose the sodium is moving through ion channel, sodium channel, or potassium is moving through ion channels. What kind of transport are they? They are simple diffusion only. They are simple diffusion only, because here the channel is not a carrier protein. Here the channel is not a carrier protein. Channel protein means only the protein will remain there and there will be gap at the center of this channel through which the molecule will move. But carrier protein means it will first attach with the substances and then it will change its conformation. After changing conformation, the molecule will be released on the other side. That is why in the question you can see here that this is the carrier protein, this purple color, this is the carrier protein. First it was open in the extracellular fluid surface. Now whenever the substances is attached with this carrier protein, now the carrier protein has changed its shape. The shape changes of the carrier protein is essential, otherwise it is not a carrier protein. Okay. So, channel protein, it does not change its shape, only it will remain either in open stage or in closed stage, and that is why any kind of movement through sodium channel or potassium channel, they are the simple diffusion only. And also we know that any kind of gaseous movement, carbon dioxide, oxygen, they are also simple diffusion. Okay. So, this is the summary of different types of transport. Now, you try to answer this question, very simple question, very simple question. Answer, all of you will answer, I know. So, insulin, okay, everybody answer. Okay. So, we all know that insulin basically act on insulin stimulated GLUT, and that GLUT is GLUT4. Okay. So, option number D. Okay. So, look at here. So, insulin stimulate these vesicles. Okay. So, GLUT4, they basically remain attached with the vesicles. Okay. Whenever insulin is there, this insulin will stimulate these vesicles, and then the vesicle will move towards the cell membrane, and after moving towards the cell membrane, this GLUT4 will be inserted into the cell membrane. This GLUT4 will be inserted in the cell membrane, and through this GLUT4 the glucose is going to enter. This is the normal mechanism of action of insulin. But here the question answer is very simple, but question can be make a little difficult, because here they are asking that if a person is doing regular exercise, then there will be decrease which receptor has insulin resistance with regular exercise. But if the person is doing regular exercise, it will decreases the dose of the insulin requirement for the patient, or you can say that there will be increase in sensitivity of the tissue. Why? Because you know that there are certain GLUT in the cell, certain GLUT4s are there in the cell, which can move towards the cell membrane, okay, and it will be inserted in the cell membrane, same like that of the insulin. But these GLUT4 are not stimulated by insulin. But whenever a person is doing exercise, the exercise will break down adenosine triphosphate inside the cell, and that adenosine triphosphate breakdown will produce 5' adenosine monophosphate, and this 5' adenosine monophosphate will stimulate GLUT4, and that GLUT4 will be inserted on the cell membrane. So, that is why we say that if a person is doing exercise, there will be more entry of glucose inside the cell, means blood glucose will decrease. This entry of glucose into the cell is independent of insulin. Even if you do not give insulin, then also doing regular exercise will causes hypoglycemia through an independent mechanism. Getting my point? So, that is why insulin is causing hypoglycemia by taking out blood glucose level into the cells. But even if you do exercise additionally, what will happen? The additional number of GLUT will input to the cell membrane, and because of which more hypoglycemia will be there. That's why we always recommend exercise for a diabetes mellitus patient, because it will reduce the dose of insulin therapy in this patient, because exercise has an independent mechanism by which it causes decreased blood glucose level. Getting my point? So, anyway, the answer of this question is GLUT4, and if I ask you GLUT4 is which type of transporter, secondary active transport or facilitated diffusion, your answer will be GLUT4. All GLUTs are facilitated diffusion. Okay, facilitated diffusion. Please try to remember this. So, here is the list of GLUT. I believe all of you know. So, GLUT4 we are discussing here. So, this is the insulin responsive GLUT, but apart from this, you note down here that GLUT1, okay, it is known as the universal GLUT, okay, and GLUT3 is present in the neuronal membrane, but GLUT1 is present on blood brain barrier. These two at least you remember. So, GLUT1, that is the GLUT which is present on blood brain barrier, means if I ask you that entry of glucose into the brain, which GLUT? Your answer will be GLUT1, because entry of glucose from capillary to brain will happen through the blood brain barrier. So, blood brain barrier is which GLUT? GLUT1. But if I ask you that because using which GLUT the neurons take glucose from the brain interstitial fluid, then your answer will be GLUT3. So, please try to remember this important difference, okay. And GLUT5 is the fructose transporter, all of you know that, and this SGLT1, SGLT2, SGLT3, they are the secondary एक्टिव ट्रांसपोर्टर, सेकेंडरी एक्टिव ट्रांसपोर्टर. ये कहाँ पे होता है हम लोग थोड़ा सा किडनी में डिस्कस कर देंगे आपको. सो दिस टेबल इज इंपॉर्टेंट टू रिमेंबर. ओके, नाउ यू एंटर इन द CVS. So, CVS first question, again a question of the NEET PG. So, try to answer this. Very simple question, I believe all of you will answer. So, what is phase 4? The phase 4 is the RMP phase. What is phase 3? The phase 3 is the repolarization phase. What is phase 0? The phase 0 is the depolarization phase. Okay, and what is phase 1? The phase 1 is the plateau phase. Phase 1 is the plateau phase. This we all know from pharmacology knowledge, from physiology knowledge, everything we know that thing. So, we know that this phase 0, this is the phase of depolarization. Here there will be entry of sodium. So, sodium entry. Then this phase number 1, the phase number 1, the potassium exit is going to happen in phase number 1. Phase number 2 means here the calcium entry will happen, parallelly the potassium exit will also happen, and phase number 3 means calcium channel closed, but potassium exit is going on from cell, and phase number 4 means that is the resting membrane potential. The sodium potassium ATPase pump has role for this resting membrane potential. So, first one, calcium channel opens in phase number 2. This is true because both calcium channel is open, potassium channel is open during phase number 2. So, this is the correct option and that is the answer. All of you have given correct answer. Very good, very good. Okay, very good. Then second one is the potassium channel in phase number 0, wrong, 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 everything is wrong. So, we cannot answer any of them. So, this is the 2 action potential. You have to remember briefly about these 2 action potential. So, just now we discussed that this is due to sodium entry, this is due to potassium exit. Sodium channel will be closed and potassium channel will open. INI-CET has asked this question once. So, you have to remember that here the main ion for phase number 1 is the exit of potassium. Main ion for phase number 0 is entry of sodium, okay. And the 2 ions, the calcium entry is happening, potassium exit is going on, that is plateau. This is the exit of potassium and this is my RMP, this is my RMP. This is my RMP. Please note down the RMP of the myocardium, that is minus 90 millivolt, right. Yes, transient potassium channel. So, that I am not going to discuss in this class because it is a LRR only, okay. So, now confusion हो जाता है कौन सा LRR हो रहा है कौन सा rapid revision, okay. So, this is LRR. Now, you look at the right hand side diagram. This is the nodal tissue action potential, SA node and AV node. Now, the nodal tissue action potential, it contain one important phase. So, from this minus 60 millivolt up to minus 40 millivolt, I always include this topic in every classes. So this phase is known as the pre-potential phase of action potential, which is also known as the pacemaker potential. Pacemaker potential. Okay. Now this pacemaker potential is due to entry of sodium through funny current. Okay. So this is the funny sodium current. Entry of calcium. Okay. That is the T-type calcium channel. That is the T-type calcium channel, and also closure of the potassium channel or potassium channel closure. All these three things you have to remember about. All these three things you have to remember about the pacemaker potential and pre-potential. पता है ना सबको, है ना, पता है कि नहीं? So the pre-potential phase, the funny current, the HCN channel is required. So first there will be opening of the funny channel here. So sodium is required, then calcium is also required. But even before the sodium entry and calcium entry, you require first the closure of the potassium channel, right? So closure of the potassium channel followed by entry of sodium followed by entry of calcium, that is the pre-potential, 3 ions. Okay. Then you are getting this depolarization phase. This is the entry of calcium through the L-type calcium channel. I am writing calcium L, that is the entry of calcium through L-type calcium channel, and then you are getting the repolarization phase. Repolarization phase is same for both the action potential, that is exit of potassium channel, and because of the exit of potassium channel again you will reach at this minus 65 millivolt, and whenever the membrane voltage is reaching at minus 65 millivolt, again your sodium entry will start, and this sodium entry is through funny channel or HCN channel. This basic thing you have to remember, HCN channel, okay, funny channel or HCN channel. इसका detail जितना भी पढ़ो कम ही होता है, but at least you should remember this ionic basis of this two action potential. Now one question here, look at the question. So a 40-year-old woman has resting heart rate of 70 beat per minute and arterial pressure is 130 upon 85, normal body temperature given. Question is very simple, although a long clinical history has been given, but question is very simple, first heart sound कहाँ पे होगा? Okay. So ये जो डायग्राम है ये हमारा कार्डियोवास्कुलर सिस्टम का प्रेशर वॉल्यूम लूप है ही ना. सो प्रेशर वॉल्यूम लूप में हम लोग जानते हैं कि पॉइंट नंबर A to B जो है ये हमारा फिलिंग फेज ऑफ वेंट्रिकल. दिस इज द फिलिंग फेज ऑफ द वेंट्रिकल. ओके, and then whenever there is filling from this B to C, this is the isovolumic contraction phase. Okay, then from this C to D, this is the ejection phase of ventricle. This is the ejection phase, and after the ejection D to A, this is the isovolumic relaxation phase of ventricle. Okay, so these different phases has been shown here in this diagram, and this is known as the pressure volume loop. Okay, so first there will be filling of the ventricle, and whenever the filling is complete, look at here, whenever the ventricular filling is done, now the ventricle will start contraction. So isovolumic contraction will be started. At the beginning of the isovolumic contraction, there will be closure of the mitral valves and the tricuspid valve. There will be closure of the mitral valve on the left hand side and tricuspid on the right hand side. So this point number B is the origin point of the first heart sound, right? Then the isovolumic contraction will be there. After the isovolumic contraction, there will be ejection of the blood. When the ejection is complete, now the ventricle will start relaxation. Just before the relaxation, there will be closure of the semilunar valves. So here at point number D, this is the closure point of semilunar valves, and semilunar valve closure means that is the heart sound, second heart sound, right? And when the ventricular filling is going on between A to B, whenever the ventricular filling is going on between A to B, this is the point where the third heart sound as well as your fourth heart sound may appear, because we all know that third and fourth heart sound are not very common. Okay, most of the cases they are pathological. Third heart sound sometimes it can be physiological. So third and fourth sound, if I ask you where they are going to happen, your answer will be between this A and point number B. Third and fourth heart sound is going to happen, but question is typically asking the first heart sound, so answer is point number B. Okay, this is pressure volume loop, and again from this pressure volume loop, in some of the other classes I have shown you that suppose they are asking what is the cardiac output of this person. Then look at this diagram. So, this is the point where the minimum volume is present in the ventricle after contraction. This 50 ml volume, this is known as the end systolic volume, and then the ventricular filling will go on. After the end of ventricular filling, when you are reaching at the point number B, this 150 ml volume, this will be known as the end diastolic volume, and the difference between them will be the stroke volume. So, if I have to calculate the stroke volume from here, it will be 100 ml, it will be 100 ml, and then if you multiply this with the heartbeat. So, stroke volume you are getting, stroke volume you got from here. So, cardiac output is equal to stroke volume multiplied by heart rate. So, heart rate is given here is the 70 and stroke volume is 100. So, 100 multiplied by 70. So, 7 liter per minute is the cardiac output of this person. Okay. So, this kind of question can also be given. So, paper very good, very good. Okay. Weir's diagram रखा नहीं है इसमें. Okay. बट पीवी लूप देखो. सो पीवी लूप का कुछ एबनॉर्मल पीवी लूप देखो. सो आउटिक रिगाइजेशन, माइट्रल रिगाइजेशन दोनों में ही देयर विल बी राइट शिफ्टिंग ऑफ द okay, right shifting of the PV loop. Okay, I have explained that why there will be right shifting, why there will be upward shifting in the main lecture, but please excuse because it's not possible in this LRR. Uyghur diagram I have explained in detail, pressure changes, volume changes. Okay, but to differentiate between this right shift, mitral and aortic regurgitation, how to differentiate? In my aortic regurgitation, there is a little upward shift also. So, apart from right shift, you have to note down that the curve is also shifting little upward direction. But this upward shift is not there in case of mitral regurgitation. Mitral regurgitation means pure right shift will be there, but in aortic regurgitation, apart from right, there will be a little upward shift also. Got it? Okay, fine. And in aortic stenosis, there will be upward shifting in case of aortic stenosis. Okay, but this upward shifting will be seen in case of acute aortic stenosis. In chronic aortic stenosis, this curve will shift in the upward direction also as well as in the leftward direction also. So, you have to remember that in case of chronic aortic stenosis, the curve will shift in the upward direction also as well as in the left hand side also, upward as well as on the left hand side. So, that is known as the counterclockwise movement of the PV loop. Okay, upward direction shift also as well as leftward direction shift also, because in chronic aortic stenosis there will be hypertrophy of the ventricle, and that hypertrophy will increase the force of contractility, that will cause left shift of the curve. Okay, and in mitral stenosis, as you can see here, that the end diastolic volume is decreasing, and because of the decrease in the end diastolic volume, what will happen? There will be leftward shifting of the curve. So, left shift of the curve is going to happen in mitral stenosis. Fine. So, quickly ये चारों को देख के रखो. Now, the next question. This question has not been asked in NEET PG yet, but soon it is going to be asked. Okay. So, look at here, one image based question. So, this image is taken from Guyton, modified image. So, which kind of exercise? If I ask you which kind of exercise the person is doing here, isotonic or isometric? Isotonic or isometric? So, if I do a isometric exercise, strong contraction करके आपको hold करके रखना होगा. In isometric exercise, the blood vessels will be compromised here because your muscle is strongly contracted. Isometric example क्या देते हो? You are pushing the wall. But more better example is, suppose I am a weight lifter, I am not, but suppose I am lifting my weight and then I am holding my weight like this, strongly I am holding my weight like this. So, what is happening? All these muscles, they are strongly contracted without any relaxation in between whenever I am holding this load. So, that is a strong isometric contraction. In strong isometric contraction, do you think the blood flow is going to increase in the muscle? Answer no. So, here what you are saying, this is the resting blood flow. This is the resting blood flow, very, very less. We say that resting blood flow in the muscle, is only 1 to 4 ml per minute per 100 gram of muscle tissue, Whenever a person exercises, okay, so in response to exercise, this blood flow increases 25 times. But they are mainly talking about which kind of exercise? That is the isotonic exercise like this. like this. Okay, with a dumbbell you are going to increase your biceps muscle mass. So, this kind of exercise, there is rhythmic contraction of the muscle and relaxation of the muscle. So, whenever the muscle is contracting, the blood flow is getting reduced, but whenever you are relaxing the muscles, the huge blood flow is increasing the muscles. So, this is the rhythmic contraction and relaxation, contraction, relaxation, contraction, relaxation. So, what it is showing that during this isotonic kind of muscle contraction, so this is a kind of isotonic muscle contraction. So, during this isotonic muscle contraction, there is huge increase in the blood flow to the muscles. What is the cause of that increased blood flow? Okay, you know that option A is also correct, B is also correct, C is also correct, D is also correct, not in human but in animal, but all four can be the cause of the increased blood flow to the muscles. But the most important reason for increased blood flow to the muscle is metabolic vasodilation. So, whenever a muscle is exercising, there will be production of various metabolites in the muscles, like for example adenosine, like for example carbon dioxide, like for example lactic acid, okay, like for example potassium. All of them will causes dilation of the arterioles of the muscle, as well as opening up of the more and more capillaries in the muscles. Getting my point? So, metabolites which is accumulating inside your muscle, that is causing dilation of the arterioles as well as opening of the more and more number of capillaries. That is why there will be increase in muscle blood flow. So, option number B is the most important. It is said that almost 50% increase. So, suppose there is an increase in blood flow to the muscle, most of the cases 50% increase in blood flow. Second. So, this 50%, it is not detecting the Apple pencil. Okay. So, the 50% increase of blood flow is due to metabolic vasodilation. Now, whenever your arteriole is dilated, if your blood pressure is high, so blood will be pushed more inside the muscle because your arterioles are dilated. If the arterioles are not dilated, then you cannot push more blood. But now here the arterioles are dilated by this metabolic activity, metabolites. Now the blood pressure is high. So, more blood pressure means more blood will be pushed into the muscle. So, this increased arterial blood pressure is responsible for another 30% increase in muscle blood flow, and remaining increase in blood flow is done by sympathetic mediated vasodilation. We know that sympathetic stimulation causes vasoconstriction mainly, but muscles contain beta 2 receptor, muscles capillaries, they contain mainly beta 2 receptor, and through this beta 2 receptor the vasodilation will happen. So, all A, B, C all are correct for human, but option number D, this cholinergic sympathetic system, this is not very important for human. So, this is not important for human, but this is important for other animals. This cholinergic sympathetic system is also responsible for increased blood flow to the muscles in lower mammals like dog and other mammals. Okay. So, that you have to remember, but not for a human. But A, B, C all can be the increased muscle blood flow for human, but most important is B. Okay. Now, next question, answer batao. So, chemoreceptor, we know that it will be whenever it is activated, it stimulates the vasomotor center. Because of the stimulation of the vasomotor center, there will be increase in blood pressure, and it also stimulate the CIC, okay, cardiac inhibitory center, because of which there will be decrease in heart rate, but heart rate can also increase if there is additional activation of stretch receptor. Okay, if there is additional activation of stretch receptor, lung stretch receptor. Okay. Cushing reflex, we have already seen that Cushing reflex, there will be increased blood pressure, there will be decreased heart rate, there will be irregular respiration, okay. These are the triad of the Cushing reflex. So, again this is not matching. Bainbridge reflex, there will be increased heart rate, tachycardia, okay. And Bejoel-Jeris reflex, yes, this is matching. There will be severe hypotension, there will be severe bradycardia, along with that there will be coronary vasodilation. Apart from coronary vasodilation, there will be apnea followed by ventilation. So these are the features of the basal gyrus reflex. So answer of this question is option number A. Please try to remember. Now few points about the Bain-Briggs reflex and basal gyrus reflex which will be helpful for NEET, INI-CET everywhere. So the receptor for Bain-Briggs reflex is stretch receptor which is present in the atrium, particularly the right atrium, right? And whenever there is increase in blood volume due to any reasons, this is very, very important, increase in blood volume due to any reason, that is a stimulus for, okay, that is a stimulus for the stretch receptor. The session will continue up to 7:30. Okay. So increased blood volume, stretch receptor, afferent is the vagus nerve, okay, and there will be increase in heart rate in response to Bain-Briggs reflex activation. And for basal gyrus reflex, the receptor is present in the ventricular wall as well as septum. Try to remember, these receptor are chemoreceptor also, they are mechanoreceptor also, both can be detected by this kind of receptor which are located in the left ventricular wall mainly, along with that septum also contain this kind of receptor. And this has been asked already in NEET and INI-CET mainly, the substances which activate this basal gyrus reflex, veratadine, serotonin, capsaicin. इतना देर तक तो क्वेश्चन आ गया ऑलरेडी. दे हैव आस्क्ड क्वेश्चन बेस्ड ऑन सेरोटोनिन, कैप्साइसिन, वेराटाडिन, बट अपार्ट फ्रॉम दैट ऑल्सो रिमेंबर ब्रेडिकाइनिन, एट्रियल नाइट्रेट पेप्टाइड, निकोटीन कैन ऑल्सो बी सब्सटेंसेस फॉर एक्टिवेशन ऑफ दिस basal gyrus reflex. And basal gyrus reflex afferent is again the vagus nerve, and whenever there is activation of this basal gyrus reflex, there will be severe bradycardia, okay, severe hypotension, coronary vasodilation and apnea. Okay. So they are not basically toxins. Sometimes in, suppose a person is suffering from myocardial infarction and you started the reperfusion therapy. So whenever you are starting the reperfusion therapy, the dead muscles, the dead myocardium can release some of the serotonin, the dead myocardium can release some of the chemicals, okay, they can also precipitate the basal gyrus reflex, okay. So like sometimes the common example that is given in basal gyrus reflex is during coronary angiography, the dye, the substances which you inject in the coronary artery for performance of the coronary angiography, if the dye is containing certain impure substances, then that can also precipitate this basal gyrus reflex, okay. Yes, coronary intervention, okay, any kind of coronary intervention or the dead muscle cells like myocardial reperfusion therapy, they can activate this basal gyrus reflex. Very good, very good. Okay. Now we are coming to the next system, that is the renal system. So the first one is the glomerular filtration barrier. Simple thing, but simple thing sometimes can become difficult. Why difficult? Because you look at here that endothelium, okay, glomerular basement membrane, podocyte food process. So the podocyte food process के बीच में जो गैप होता है उसका हम लोग बोलते हैं स्लीट पोर, राइट. तीनों जगह पे देयर इज नेगेटिव चार्ज. सो द ग्लाइकोकैलिक्स कोटिंग व्हिच इज प्रेजेंट ऑन द एंडोथेलियम सेल, द हेपरन सल्फेट प्रोटियोग्लाइकन which is present on this basement membrane, and this hyaloglycoprotein which are present on this podocyte food process, all of them are negatively charged. So please remember, this is also negative charge, this is also negative charge, this is also negative charge, means filtration barrier is a negative charge and this negative charge is present in all three layers. Now don't confuse that this protein which has been written here, this is podocin. No, this is not podocin. This is the negative charge protein which is covering the food process of the podocyte. So suppose this is the food process of the podocyte. Between these two food process, the distance or the gap is known as the slit pore. Just now I told you slit pore. Now this slit pore contain one diaphragm, that is known as the slit diaphragm. This slit diaphragm contain additional protein, that is the nephrin, podocin. So all of this nephrin, podocin that you know, that is present in this slit diaphragm. But I am talking about that this podocyte food process, it contains a sialoglycoprotein covering, and that sialoglycoprotein name has been written here, that is podoclixin and podoendin. So these are the basically sialoglycoprotein that you have to remember, okay. Now on the right hand side, what is written here is the filterability of different substances. Based on this, the question has been given in INI-CET also and NEET also, that if the radius of the molecule is less than 1 nanometer, radius में बोल रहा हूँ, diameter में नहीं, okay, then it is a freely filterable substances, and all the substances which has been written here, they are freely filterable substances. You can find out here the pH is also there, the inulin is also there, pH लिखा नहीं है, but pH is also in the freely filterable substances. Then coming the selective permeable. Selective permeable means if the molecular radius is between 1.8 to 4.2 nanometer, then the filtration barrier will select that whether the molecule is going to pass through or not, depending on the charge. So, in these cases, if the molecule itself is a positively charged, so the filtration will be more than neutral molecule, which is more than that of the negatively charged molecule. Means if the molecule which is going to filtrate, if that itself is a negatively charged, then the filtration will be least. But if the molecule which is going to be filtrate, that is positively charged, then the filtration will be more. Okay. So, suppose the molecular radius for all these three substances, you have taken one positively substance, one negatively charged, one neutral substances and one negatively charged substances, and all of them has a molecular radius which is in between this range. Then between among these three substances, the maximum filtration will be seen for the anionic, cationic molecule, followed by neutral, followed by anionic molecule. Okay. And if the substances radius is greater than 4.2, so that is impermeable substances. Okay. Now, next thing is the regulation of the GFR, again important topic for INI-CET. So, regulation of the GFR is done by three mechanisms. One is the myogenic mechanism, okay, myogenic mechanism and tubuloglomerular feedback. Question for you. Okay. Myogenic mechanism, what is the ion responsible for myogenic mechanism and what is the ion responsible for this tubuloglomerular feedback mechanism? Myogenic mechanism bolo and tubuloglomerular feedback. Type your answer. Yes. And for tubuloglomerular feedback, कितना याद है देख रहा हूँ. Yes. So, myogenic mechanism, myo means smooth muscles of the arterioles. So, contraction of the smooth muscles of the arterioles will happen if there is stretch of that smooth muscle, and this is mediated by calcium ion. So, this is calcium ions mediated. Okay. And very good. This tubuloglomerular feedback mechanism, this is mediated by adenosine. What is the receptor cells for this tubuloglomerular feedback mechanism? That is macula densa cell. Macula densa cell is the receptor for this tubuloglomerular feedback mechanism. Okay, because from the tubule the feedback will originate, and which part of the tubule? The macula densa cell region of the tubule, which is the uppermost part of the thick ascending limb of loop of Henle, that is the macula densa, right? Okay. And the third mechanism for this autoregulation is angiotensin II mediated vasoconstriction. Apart from that, the afferent arteriole efferent arteriole resistance is also responsible for controlling the GFR. How this afferent and efferent arteriole is going to control your GFR? Look at here. So, try to look at this image. It can be given as an image based question also, but also theoretical question also. So, x axis in this diagram is the afferent arteriole resistance and लिखा है multiplied by normal, means normal से कितना time ज़्यादा है. So, if it is written 1 here, that is the normal resistance. 2 here means twice that of the normal, 3 thrice and 4 times that of the normal. So, whenever you are causing constriction of the afferent arteriole, so if you are causing constriction of afferent arteriole, then there will be more and more increased resistance of the afferent arteriole. In this condition, what is going to happen? This is very simple. There will be decrease in the renal plasma flow also and GFR also. So, this is the renal plasma flow as is shown here, and the glomerular filtration rate both will decrease proportionally. So, initially the GFR as well as the renal blood flow was very high, but whenever you are causing constriction of the afferent arteriole more and more, the GFR is also decreasing and the renal plasma flow is also decreasing. Both will decrease. That is very simple to understand. But if you do the same thing for the efferent arteriole, if you are causing constriction of the efferent arteriole, so this is normal, then twice that of the constriction or increase in resistance twice that of the normal, 3 times that of the normal and 4 times that of the normal. So, what will happen in these cases? So, what you are doing here, this is nothing but constriction of efferent arteriole. In these cases, more you constrict the efferent arteriole, there will be proportionate decrease in the renal blood flow. There will be proportionate decrease in the renal blood flow. So, efferent arteriole को constriction करो, otherwise afferent को constriction करो, whether वो constrict afferent or efferent, both the cases there will be decrease in renal plasma flow because you are increasing the resistance. Okay. So afferent efferent दोनों को किसी को भी constriction करो, there will be decrease in the renal plasma flow because there will be increase in resistance. But in case of efferent arterial constriction, initially the GFR will increase, but later on the GFR will decrease. So we remember like this, that if you causes constriction of this afferent arteriole, if you causes constriction of this afferent arteriole and efferent arteriole, in case of afferent arteriole there will be reduction in the GFR, there will be reduction in the renal plasma flow. But if you causes constriction of the efferent arteriole, there will be always reduction in the renal plasma flow, but GFR will increase if the constriction is mild constriction. Mild constriction means 2 times that of the normal resistance, that is the mild constriction, and GFR will reduce to very low level. Okay. GFR will reduce to very low level if there is severe constriction. Severe constriction means 3 times that of the normal resistance. Okay. Again, explanation will take time, please excuse me in this session. Okay, but as you can understand ki if you constrict very severely, the blood flow will reduce to a very low level, that the GFR is going to be reduced. But if you causes mild constriction, the blood flow will reduce, but the blood which is entering in the capillary, it will not be able to go out of the capillary easily. So it will stay there for long duration. So if blood is staying there inside the glomerular capillary for long duration, so it will increase the glomerular capillary hydrostatic pressure, and that will increase the GFR. So that's why initially the plasma flow will be reduced, but that reduction is not very severe. But although the plasma flow has been reduced, but that plasma is staying in the glomerular capillary for long duration because efferent is constricted. But in severe constriction, the renal plasma flow is reduced to a very low level, and the reduction is so severe that even after staying of this blood in the glomerular capillary for long duration, the pressure will not increase proportionally because the amount of blood is very low. Okay. That is the initial, but in main classes I have given the detailed explanation for this, or this is the 2 minutes explanation that I can give here. Okay. Now the next is the clearance. So why I have written the formula of the clearance, because one question was there in the NEET exam, that what is the meaning of this U, what is the meaning of this V, what is the meaning of this P. I believe that is the INI-CET question. So U is the urine concentration of the substances. What is the unit? Please remember this. This has been asked. What is the V? V is the urine flow rate. Unit is ml per minute, and the P is the plasma concentration. Again, the unit is milligram per ml. So unit plus what is the meaning of this U V by P, that you have to remember. But this clearance is equal to U V by P. The literal meaning of this U V by P, the literal meaning of this urinary amount of the substances upon your plasma concentration. Because if you multiply U and V, what you are getting? You are getting what is the substances in the urine, urinary amount of the substances upon your plasma concentration. Now urinary amount of substances means the urine substances will appear by the process of filtration plus secretion minus absorption. If I ask you that what is the source of the substances, any substances in the urine, you will say that, sir, first it will come from the filtration, then later on some maybe come from the secretion, certain substances will be secreted, and then if there is reabsorption, then urinary amount will be less. So filtration plus secretion minus absorption upon your plasma concentration, that is the actual formula of the clearance. Now we know that if you measure the clearance of a substances inulin, clearance of a substances which is inulin, we know that for inulin neither there is reabsorption, neither there is secretion. Means if you measure the clearance of inulin, then you are going to get the filtration amount, filtration rate. And what is the name of the filtration rate? That is the GFR. That is why we say that inulin filtration, inulin clearance will give you the filtration rate estimation, and that is why we use the inulin clearance as the GFR estimation. Now if there is secretion of any substances in the urine, then what will happen to the clearance of that substances? The clearance of that substances, if there is secretion, so filtration plus secretion, so urinary amount will be more. So urinary amount is more means the clearance will be more than, so more than inulin clearance. So that's why we write down this sequence, that if a substances is secreted in the urine, then the clearance of that substances will be higher than that of the inulin clearance, like for example creatinine. Okay. Similarly, the para-aminohippuric acid, the clearance of para-aminohippuric acid is maximum among all, because there is huge amount of secretion of para-aminohippuric acid in the urine. And if there is reabsorption of any substances in the urine, okay, or in the nephron, then what will happen? The urinary amount will be less, the clearance of that substances will be less. That is why we say that more the reabsorption in the nephron, lesser will be the clearance than that of the inulin. Okay. So, like for example, clearance of urea is less, more lesser is clearance of sodium, and clearance of glucose is the least, because glucose, amino acid, all these substances they are 100% reabsorb in the urine, 100% reabsorption. So, last में जो मैंने लिखा, that is a clearance of glucose and amino acid, because glucose and amino acid they absorb almost 100% in the nephron. So, the clearance will be least among all of this. Okay. So, this sequence you remember, based on this sequence, based on this concept, you may get many MCQs. Now, you look at one image based question from NEET entrance examination. So, whenever any kind of image is given, this is my general advice to you. Please first look at the x axis first, y axis first, and then you look at what is given inside this image. So, if you look at the x axis here, you are getting that Bowman space, proximal tubule, distal tubule, urine is given, means different segment of the nephron has been given in this. Okay. And in y axis, what is given? Percentage of filtral load remaining, and 100 is given. So, 100% means that 100% is at the level of Bowman space, means this is the filtration. So, whenever there is filtration of a substance in the urine or in the Bowman's capsule, we are taking that percentage into 100%, and then I am finding out that throughout the different parts of the nephron, this substances is increased, means there must be secretion of these substances in the urine. Now, secretion graph can be here also. Okay. So, this is also secretion. Okay. This is also secretion. Okay. But dono secretion means difference is that the first one secretion is very huge secretion. So, this is most probably the pH, and this is most probably the creatinine. Okay. Now, if you look at the C number curve, there is no change in concentration of these substances, there is no change in amount of these substances throughout the urine. So, this is basically inulin, no secretion, no reabsorption. Okay. And then you can find out here option A and B, both of them are reabsorbed in the urine, but if you follow this B, the B reabsorption is going on. Almost 100%, not 100%, almost 100% reabsorption. That is why we are finding out that this curve is never touching the x axis. That means, in the urine there will be excretion, but very little excretion. So, it may be water, it may be sodium, it may be potassium, because we know the sodium 99.9% reabsorb, bicarbonate also, yes, bicarbonate 99% reabsorb हो जाता है. It can be water also, water भी reabsorption हो जाता है. So, these are the substances which is like sodium, like bicarbonate. Okay. There will be reabsorption, but even little amount will be excreted in the urine. And if you look at the option number A, this curve A is touching the x axis even within the proximal tubule only, means proximal tubule जाते जाते पूरा 100% reabsorb हो गया. And this is typically the glucose and the amino acid which are 100% reabsorb. So, यहाँ पे question में पूछा है what is the D, curve number D. So, the curve number D is the para-aminohippuric acid. All of you got it, everybody? Okay. Okay. Now, we are going to discuss the glucose transport in the nephron, because the detail of the glucose transport sometimes asks. So, suppose this is the lumen of the nephron. So, this is the lumen of the nephron. So, and this is the cell, this is the cell. Which part of the cell? This is the proximal convoluted tubules, and this is the proximal straight tubule. So, proximal tubule has two parts. First part is the convoluted portion and the last part of the proximal tubule is the straight one. So, proximal convoluted tubule and proximal straight tubule. So, proximal convoluted and straight tubule. Now, at the level of proximal convoluted tubules, the luminal transporter for glucose transport, bolo, what is the transporter? Everybody? What is the transporter? So, this is SGLT, but आपको टाइप बताना होगा SGLT. So, yes, so at the level of PCT this is SGLT2 and at the level of PST SGLT1. SGLT2 responsible for 90% reabsorption, it is responsible for 10% reabsorption. So, SGLT means it will reabsorb sodium and glucose in both the cases. Here also the sodium as well as glucose, but you know that SGLT2 has a ratio of 1:1, but SGLT1 has a ratio of 2:1, means 2 molecule of sodium is to 1 molecule of glucose, but in the SGLT2 it is 1:1. So, you have to remember this. Okay. And for proximal convoluted tubule, after the entry of the sodium and glucose into the cell, the glucose has to be reabsorbed from the basolateral aspect. Okay. So, this glucose has to be reabsorbed from the basolateral aspect by a transporter. This transporter here is GLUT, GLUT. Which GLUT? GLUT2. So, if it is an SGLT2, then the basolateral membrane will have GLUT2. So, many things, very simple thing, but many things can be asked from here. So, in the lumen it is SGLT2, it is a secondary active transporter. In the basolateral membrane it is GLUT2, that is a facilitated diffusion. So, if it is SGLT2, the GLUT2 will be present on the basolateral aspect. If it is SGLT1, then the basolateral aspect will contain the glucose transporter, that is GLUT1. So, this is GLUT1 here. Okay. So, that is why in the GLUT table we have mentioned that GLUT1 is also present in the basolateral aspect of the proximal tubule, the proximal state tubule, right. So, please try to remember all of this information because they are important for MCQ. Okay. But again I am repeating that GLUT1 is the facilitated diffusion, SGLT is the secondary active transport. Okay. Now, we are moving into the respiratory system. So, easy question, repeat question, answer batao. So, all of you know this. IRV, okay. This is ERV, okay, and this is RV, and obviously you know that this is my tidal volume. Okay, very good. Obviously you are going to give me correct option. So, here the line that is given here in the curve, okay, इसको अच्छे से ध्यान देना है कौन सा जगह पे मार्क करके रखा है, ठीक है, क्योंकि वो इमेज थोड़ा सा देख के चेक करना होगा ना. सो ये ERV प्लस RV ये दोनों का कॉम्बिनेशन. सो वी ऑल नो दैट ERV एंड RV दोनों का कॉम्बिनेशन इज नोन एज द FRC. सो FRC इज ऑल्सो नोन एज द resting lung volume or the relaxation volume of the lung, relaxation volume of lung, okay, resting volume or relaxation volume of the lung, these two things you have to remember. Okay. Now, the next is compliance. So, sometimes this kind of curve is given and they will ask you to calculate the compliance of the lung in this case. Okay. So, compliance, you look at x axis, it is the pressure, and what is y axis? Lung volume. We know that the formula of compliance C is equal to delta V upon delta P, means you have to calculate what is the change in volume and what is the change in pressure. So, what you are going to do? You are going to drop on perpendicular from this point which is marked in the y axis. So, from here you are dropping on perpendicular on this curve, okay, and then after dropping this perpendicular you are going to drop another perpendicular here on the x axis, okay, another perpendicular on the x axis. So, two perpendicular I have made, and now I have to take another one. So, now from this 6 liter and now I am dropping on perpendicular from this 4 liter. So, from this 4 liter I am dropping on perpendicular on this compliance curve, and then from there I am extending this perpendicular on the x axis. Done. So, what I have done, I have taken 2 points on this exponential part of the compliance curve, and I have made one perpendicular, okay, from here on this curve and then onto the x axis, same way from here and then onto the x axis. So, now if I calculate the difference between these 2 points, this is the volume change in the y axis, this is my delta V, and if I calculate the change in between these 2 points, this is my pressure change, this is my delta P. So, now I can easily calculate the compliance of this curve. So, delta V here 4 liter to 6 liter. So, this is 2 liter, means this is 2000 ml, right, and here the pressure is changing from 10 to 20, whatever pressure may be given, is may be given in the interpleural pressure, it may be given transpulmonary pressure, do not look at it, you look at how much of the pressure change is happening. So, volume change upon pressure change. So, pressure change is 10 to 20, so that is 10 centimeter of water, 10 centimeter of water. So, obviously, this will be 200 ml per centimeter of water, right. So, this 200 ml per centimeter of water is the compliance of this person. Meaning of this 200 ml is that if I change 1 centimeter of pressure in this lung, then 200 ml expansion of the lung is going to happen. So, compliance is, okay, expansibility of the lung, how easily the lung is expansile. Now, whenever we are talking about compliance, we have to remember that in disease condition, the compliance can be high, the compliance can be low. So, you have to remember that high compliance means you must have to remember the name of this disease, that is emphysema, okay, and little bit of asthma, but not very high. Asthma compliance is almost normal and bronchitis compliance is bilkul normal. Okay. So, इसलिए I am not writing COPD, all cases of COPD will not have high compliance, the emphysema must have, okay. Asthma, chronic asthma may be a little higher, but bronchitis compliance is almost normal. But all cases of restrictive disease, like for example fibrosis हो जाए, maybe myasthenia gravis हो जाए, in all these cases the compliance will be low. So, please remember that compliance high, compliance low. Compliance high means emphysema. So, if there is high compliance, then you will get a compliance curve which is above the normal curve. So, suppose already the question has told you that this is the normal curve. So, obviously, any curve which is above this curve, this will means high compliance curve, and any curve which is below this normal compliance curve, that will have the low compliance curve. Very simple, but sometimes हम लोग क्वेश्चन एग्जाम में गड़बड़ कर लेते हैं. So, प्लीज़ इसको ध्यान रखो. Okay. Okay. So, ये हो गया compliance curve. Now, next is the very famous topic. Okay, you know that what is the importance of this topic. Every alternate exam में ये topic से question दिया जाता है, whether it is INI-CET, whether it is NEET, everywhere. So, we all know that this OHDC, oxygen hemoglobin dissociation curve, इसको आपको पढ़ के जाना ही होगा. क्या क्या एक बार देख के जाना ही होगा. So, oxygen hemoglobin dissociation curve, ये curve का shape जो होता है compliance and surfactant. Okay. So, just look at this concept. Suppose this is your alveoli. Okay. Suppose this is your alveoli. You are trying to expand this alveoli like this. If the expansion is easy, then high compliance. If the expansion is low, then it is low compliance. Okay. So, the surface tension is an inward directed force. Okay. Surface tension, if it is high, it will try to cause collapse of the alveoli, as well as the elastic tissue which is present surrounding this alveoli, they are also the inward recoiling force. So, elastic tissue and surface tension, they will try to decrease your compliance, because whenever my elastic tissue is very, very strong, what will happen to the expansion? Decrease. If the surface tension is very, very strong, then again it will not allow the lung to expand, means more the surface tension, more the elastic tissue, lesser will be the compliance. Now, you tell me if there is more surfactant. So, surfactant reduces the surface tension. So, what will happen to compliance? Compliance will increase. That is why the question is given that in case of hyaline membrane disease, what will happen to compliance? The compliance will be low. Okay. So, you know that thing. Okay. Now, you look at the next thing is that this OHDC curve. So, you have to remember that what is the cause of the right shifting of this curve. So, increased temperature, increased partial pressure of carbon dioxide, increase H plus ion, increase 2,3-DPG. And we all know that if there is right shifting of the curve due to presence of increased carbon dioxide or due to presence of increased H plus ion, that right shifting is known as the Bohr effect. Okay. And increased 2,3-DPG, what is the cause of this increased 2,3-DPG? So, any cases of anemia, hypoxia, exercise, increased thyroid hormone, increased growth hormone, increased androgen production, and presence of iodine, pyruvate, phosphate inside the RBC, all of them will causes increased 2,3-DPG. Increased 2,3-DPG means there will be right shifting of the curve. Okay. So, this 2,3-DPG, one molecule of 2,3-DPG binds with one molecule of hemoglobin. 2,3-DPG, one molecule of 2,3-DPG binds with one molecule of hemoglobin, and after binding it causes hemoglobin in a relaxed condition, because of which oxygen release will be more, and because of the oxygen release there will be right shifting of the curve. That is why we say more the 2,3-DPG, more will be the right shifting of the curve, and all the causes of the increased 2,3-DPG has been written here. Okay. Now, whenever you are asking for reading for right shifting, the left shifting of the curve is equally important. So, left shifting, first one is the fetal hemoglobin. Why fetal hemoglobin will be left shifting? Because in the fetal hemoglobin we know that alpha 2 and gamma 2 chain is there rather than beta 2 chain. So, here we have discussed that one molecule of 2,3-DPG binds with one molecule of hemoglobin. If I ask you 2,3-DPG binds with which chain of the hemoglobin, then your answer will be beta chain. 2,3-DPG binds with beta chain. So, if the beta chain is absent, then 2,3-DPG cannot bind with the hemoglobin, and if the 2,3-DPG content is less, then there will be left shifting of the curve, and because of the same reason the fetal hemoglobin will have left shifting of the curve because it contains gamma chain which cannot bind 2,3-DPG. Okay. Storage of the blood, whenever you store blood in the cold environment, whenever you store blood in the acidic solution, both of them will reduce the 2,3-DPG content of the stored blood. So, that is why in case of storage blood there will be left shifting of the curve. Carbon monoxide poisoning. So, whenever there is carbon monoxide poisoning, carbon monoxide binds with hemoglobin with higher affinity, but that is not the reason. Whenever one molecule of carbon monoxide binds with hemoglobin, the other oxygen molecule which are already attached with hemoglobin, they will have high affinity state. Getting my point? So, suppose already two molecule of oxygen is there and one molecule of carbon monoxide is attached with hemoglobin. Now, the two molecules which are already attached, they will not be able to release from the hemoglobin higher affinity. So, higher affinity means which shift? Left shifting of the curve. Okay. Then methemoglobin, the same reason like that of the carbon monoxide poisoning, high affinity oxygen state, whenever the iron is converted into ferrous to ferric state, then that is methemoglobin, high affinity oxygen state. And thalassemia, for unknown reason there is left shifting of the curve. But in this diagram you can find out here the adult hemoglobin curve is given, followed by this fetal hemoglobin, उसके बाद एक myoglobin curve देके रखा है. We although say that myoglobin is the left shifting of the oxygen hemoglobin dissociation curve, but this is not basically shifting. Myoglobin contain only one, myoglobin can binds how many molecule of oxygen? Only one molecule of oxygen. Hemoglobin can binds 4. Because hemoglobin can binds with 4 molecule of oxygen, there is a cooperative binding property of the hemoglobin, and that is why the curve is the sigmoid shaped. Myoglobin, because it binds only one molecule of oxygen, whenever one molecule of oxygen enter into myoglobin, there will be rapid increase in saturation, and the curves normally looks like rectangular hyperbola. And this rectangular hyperbola, if you compare with the normal curve, then it is obviously placed on the left hand side of the normal curve, but this is not left shift. This is the normal curve of myoglobin, which is the shape of rectangular hyperbola type of curve, hyperbolic curve. Getting my point? So, because it contain only one it binds with only one molecule of oxygen, so cooperative binding property is not seen in myoglobin. That is why whenever one molecule of oxygen enters, sudden change in saturation will be there. Okay. So, this is all about left shifting and right shifting. Now, another important topic in the respiratory system is high altitude physiology. Okay, INI-CET NEET दोनों में. So, you have to remember 3 diseases: acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema (HAPE). Acute mountain sickness, generally it develops within 24 hours of high altitude ascent. Okay. So, within first 24 hours, if the person is having symptoms of severe headache, anorexia, nausea and alteration of the sleep, then that is indicating that brain is having edema, mild edema, and that is known as the acute mountain sickness. Most of the cases the edema fluid is accumulated in the corpus callosum. Okay. Now, if the edema is gradually accumulating and severe edema is developed inside the brain, then along with these regular symptoms of acute mountain sickness, there will be ataxia as well as mental changes, and whenever this change is happening, then this acute mountain sickness will be known as the high altitude cerebral edema. High altitude cerebral edema. So, severe form of edema will be there in the corpus callosum region. Okay. And we say that if the person is developing respiratory symptoms after 2 to 4 days of altitude ascent, and if the symptoms are related to respiratory problem, like for example cough, dyspnea, sputum production, scanty sputum, then the person is suffering from high altitude pulmonary edema. So, most of the cases the diagnosis is done clinically, because in high altitude you are not going to get the facilities. Okay. After later on in descent the investigation can be done, but initially based on these symptoms the diagnosis is done, and after diagnosis the treatment. And you told already that the most important and most reliable treatment is the oxygen and rapid descent to lower altitude, particularly 1000 meter altitude में आपको वापिस आना होगा. So, immediate descent to the low altitude at 1000 meter as well as supplemental oxygen in any format. ऑक्सीजन देना ही होगा और आपको नीचे आना ही होगा. कौन सा डिजीज में? तीनों में. एक्यूट माउंटेन सिकनेस हो जाए, हाई ऑल्टीट्यूड सेरिब्रल एडिमा हो जाए, हाई ऑल्टीट्यूड पल्मोनरी एडिमा हो जाए, सब में जो बेसिक प्रॉब्लम है हाइपोक्सिया, तो हाइपोक्सिया को करेक्ट करना होगा. सो आपको डिसेंड करना होगा एंड ऑक्सीजन सप्लीमेंट देना होगा. इसके साथ दोनों डिजीज में हाई ऑल्टीट्यूड सेरिब्रल एडिमा में कॉर्टिकोस्टेरॉइड दिया जाता है एंड हाई ऑल्टीट्यूड पल्मोनरी एडिमा में जनरली कैल्शियम चैनल ब्लॉकर दिया जाता है, बिकॉज इन हाई ऑल्टीट्यूड पल्मोनरी एडिमा में वेसोकॉन्स्ट्रिक्शन होता है. हाइपोक्सिया में पल्मोनरी वेसोकॉन्स्ट्रिक्शन होता है ना, तो वेसोकॉन्स्ट्रिक्शन क्यों होता है? स्मूथ मसल का कॉन्स्ट्रिक्शन क्यों होता है? कैल्शियम के कारण. इसलिए कैल्शियम चैनल ब्लॉकर आप दोगे तो हाई ऑल्टीट्यूड पल्मोनरी एडिमा में ज़्यादा बेनिफिशियल होगा. बट जो हाई ऑल्टीट्यूड सेरिब्रल एडिमा है, सेरिब्रल एडिमा क्यों होता है? क्योंकि परमिएबिलिटी बढ़ जाता है. सो उसको कम करने के लिए कॉर्टिकोस्टेरॉइड इज रिकमेंडेड फॉर दिस एक्यूट माउंटेन सिकनेस एंड हेस. एंड यू डोंट कन्फ्यूज दिस एसिटाजोलामाइड is not the therapy, it is for prophylaxis. So, acetazolamide is given for prophylaxis because it facilitates acclimatization in the high altitude. You know the meaning of acclimatization. If the body is adapting with the high altitude, then this symptoms, this disease is not going to happen. That is the process of acclimatization. उसमें ventilation आपका बढ़ जाएगा, RBC बढ़ जाएगा, hemoglobin बढ़ जाएगा. Okay, so धीरे धीरे आप वहाँ पे जाके acclimatize हो जाओगे, adjust हो जाओगे. But if that acclimatization is not happening, then the disease will arise. The acute mountain sickness, HAPE, HACE सब. So इसलिए हम लोग prophylaxis दे देते हैं so that the acclimatization happens easily in the high altitude. Getting my point? So this concept you have to remember. Okay. Now we are coming to the next one, that is the GIT. So GIT I have kept only 2-3 topics. Okay, the most important topics in the GIT. One is the basic electrical rhythm or the basal electrical rhythm. So I told you always in my class that basic electrical rhythm or basal electrical rhythm, this is nothing but the resting membrane potential of smooth muscle. Resting membrane potential of smooth muscles of GIT, smooth muscles of GIT. Okay. So, the resting membrane voltage in case of smooth muscle of GIT, they generally fluctuate from one membrane voltage to another membrane voltage like this. There will be fluctuation of the membrane voltage like this. Now, question, why the membrane voltage is fluctuating? Because of the presence of a pacemaker cell in the GIT. So, this pacemaker cell is the origin point of the basal electrical rhythm in the GIT, and we all know the name of this pacemaker cell is interstitial cells of Casals or Cahals बोला जाता है. Okay? Interstitial cells of Casals, right? Okay. Now, this pacemaker cell will produce the rhythmic fluctuation of the membrane voltage. This rhythmic fluctuation has a particular rate that in 1 minute, okay, how many rate you are getting in this basal electrical rhythm. So, the rate is written here, stomach is 4 per minute, duodenum 12 per minute, jejunum 11, okay, ileum 8, cecum 2 and sigmoid colon 6. Now, they will give you an image based question, particularly in INI-CET exam, and they will ask you that this BER has been recorded from which segment of the GIT. Image is given, question is this BER is recorded from which segment of the GIT. What I am going to look at? I am going to look at that how many BER is appearing in 1 minute. How to calculate? I will look at the x axis. So, x axis here it is given, this is 10 second. So, I can find out that within this 10-second duration, how many BER I am getting? 1 BER, 1 basal electrical rhythm. So, in 10 second I am getting 1. So, in 1 minute how many I am going to get? I am going to get 6. So, this is the sigmoid colon recording. Getting my point? So, this we have to identify. Okay. Then you look at here that if the normal BER is going on, like this, the muscle contraction is not going to happen, but on the top of this BER there will be appearance of this kind of potential. Okay, you can find out here. What is the name of this? This is spike potential. So, spike potential is basically action potential, you can see here. Okay. So, if the normal BER is going on like this, muscle contraction is not going to happen, but whenever the BER is getting spike potential on the surface, then the muscle contraction will happen, and more the frequency of this action potential or spike potential, more stronger will be the contraction of the smooth muscle. That is why if you look at here this lower graph, what is this lower graph? The lower graph is the mechanical recording. Mechanical recording means it is the tension, it is the force that is recorded. So, this is the high force contraction here and this is the low force contraction here. Why? If I count the frequency of spike potential here, this is high frequency. If I count the frequency here, this is low frequency. That is why this is behaving like strong contraction, this is low strong contraction. Getting my point? So, this way you have to remember that BER is a basic electrical rhythm, but whenever the action potential or spike potential is appearing on the surface of the BER, then BER is causes muscle contraction. More the frequency of the spike potential, more stronger will be the contraction. Got it? So, this rate is important and this concept is important. Then I have kept what is the stimulus for 3 main different hormone of the GIT. At least you have to remember what is the best stimulus for these 3 hormone. Peptides is the most potent for the gastrin, peptides is also the most potent for CCK, but this acid is the most potent stimulus for secretin. Then also remember that which one is not a stimulus for this hormone. So, carbohydrate is not a stimulus for this secretin also, CCK also, as well as this gastrin also. So, carbohydrate food is not a stimulus for any of these 3 hormone, and the most potent stimulus कौन सा वो यहाँ पे लिखा है, बाकी आपको ध्यान दें, बाकी आप पढ़ लेना ये क्या क्या लिखा है. Okay. Then next is the absorptions of various nutrients in the GIT. So, again this is a little controversial question, but whatever evidence I have given in my main lecture also, as well as whatever evidence I got, you have to remember that carbohydrate, protein, fat तीनों का ही maximum reabsorption होता है at the level of duodenum followed by jejunum. Okay, duodenum followed by jejunum. Folic acid and iron, again the maximum reabsorption at the duodenum, and bile salt and cobalamin maximum reabsorption at the level of distal ileum or terminal ileum. You know that thing. Okay. Now, the water reabsorption in the GIT, the total approximate water reabsorption in the GIT is 8.8 liter, maximum reabsorption of water in the jejunum. So, this is the most important thing that you have to remember from this slide. Okay. So, this is all about the GIT, and now we are entering in the last topic, that is the endocrine physiology, certain most important topic. So, one MCQ is here, repeat MCQ. So, I believe you are going to give me the correct answer. Tell me what is the answer. What is the answer? Yes, yes, yes. So, in this question you are finding out that this is one cell another cell is located here. This is the secretory cell. This secretory cell is producing some product. The substances is going to the nearby cell by the process of diffusion maybe. So, by the process of diffusion the substances is moving to the nearby cell and then it is acting on the nearby cell. So, this is typically of paracrine type of secretion. Now, all of you know what is the meaning of all of this thing. So, endocrine secretion means the substances will be secreted from a gland, then it will enter in the blood vessel and through the blood vessel it will move into the distant target organ, that is known as the endocrine type of signaling, endocrine signaling, right. Then second type of cell signaling is the paracrine. We have just discussed that it will be secreted from one cell and it will go to the nearby cell and it will act on that. That is paracrine. Like for example, somatostatin inhibit the acid secretion, parietal cell in the stomach, that is paracrine secretion. Then autocrine, from the name I can easily understand that it is secreted from the same cell and it is acting on the same cell, so that is autocrine. And the juxtacrine is a little different from paracrine. So, if you look at here, para and juxta, in both the cases, both the cells are located close to one another, but in juxtacrine the cells are located so close to one another that the ligand from one cell is interacting with the receptor of the another cell, means almost these two cells are touching with one another, almost these two cells are touching with one another. That is the meaning of this kind of juxtacrine cell. Okay. So, juxtacrine signaling means these two cells are located so close with one another that ligand is touching the receptor of another cell. So, you are asking why not C? C के लिए there will be a better kind of diagram will be given. There will be multiple pits should be shown here, multiple pits should be shown here, and from that pits the released should be shown here, that will be known as the merocrine. But obviously, this nearby cell should not be shown in the paracrine, I mean merocrine type of secretion. Okay. So, nearby cell is shown means this is paracrine type of signaling, okay, because it is clearly seeing that substance is released from one and acting on the other one. Okay. But if it is merocrine, only one cell is sufficient to show the merocrine type of secretion. Okay. So, this is different types of cell signaling. Now, the next one, this is another topic which is you have to read in endocrine physiology at least. If you I mean suppose you are not getting time, so endocrine physiology you may not revise, you can answer some of the question from your medicine knowledge also, but this receptor portion you have to look at, okay, because direct question will be given and memory based question will be given. So, look at here. So, we know that there are G protein coupled receptor. So, G protein coupled receptor, G protein can be of three types, GS, GI and GQ. Okay. So, G protein coupled receptor can be of three types, that is the G protein, GS, GI and GQ. Okay, GQ. So, the alpha subunit is different in all of these three different types of G protein. So, one is the GS, that is the stimulated G protein, GI inhibitory and GQ is the third type of G protein. Now, GS and GI, both of them act on adenylyl cyclase AC, remember, and GQ act on phospholipase C. So, this minute difference you have to remember, phospholipase C. So, whenever it is GQ, it is the phospholipase C and the second messenger is DAG and calcium, and this DAG and calcium is going to act on the protein kinase C molecule. But if it is GS or GI, then it will act on adenylyl cyclase and the second messenger is CMP, increase or decrease, and this CMP will act on protein kinase A. So, this difference you have to remember, because they will give you question that this hormone act through which of the type of receptors. So, look at here, GI के थ्रू, GS के थ्रू कौन सा हार्मोन काम करते हैं यहाँ पे लिखा है. So, these are the examples of this hormone, and the hormone which act through this GQ receptor, GQ, G protein receptor, this is very important because here calcium is the second messenger. Many times the question has been asked here that which of the following hormone act through release of calcium. Okay. So, these are the all hormone TRH, GnRH, GHRH, oxytocin, ADH1 receptor, adrenergic receptor, all these are the example of GQ type of receptor. Now, apart from this, in this diagram also it has been shown that there are certain receptors which act through guanylyl cyclase receptor which produce cGMP as the second messenger, and the hormone is nitric oxide and ANP, important. Then we have tyrosine kinase receptor. the tyrosine kinase receptor can activate two different pathway, RAS, RAP, MAP kinase pathway, or it can also activate AKT MAP kinase pathway. Don't try to look at what is the full form of this RAS, RAP और सब जरूरी नहीं है, telling you, okay, जरूरी नहीं है, आपको कोई पूछेगा भी नहीं, but you have to remember that which hormone activate this RAS, RAP pathway. The hormone is EGF, epidermal growth factor, and the nerve growth factor, and AKT MAP kinase pathway, the hormone is insulin and IGF. So remember, insulin and IGF, they act through the tyrosine kinase receptor, same for this EGF and NGF. So they act through the tyrosine kinase receptor, there is no confusion, but nowadays they are asking question about this small molecule, that which pathway is activated by this which hormone is activating this RAS-RAP pathway, which hormone is activating this AKT MAP kinase pathway. Same way, this question has already been asked in the MCQ, that JAK-STAT pathway is activated by which hormone. So JAK-STAT pathway is activated by growth hormone, prolactin, and leptin also, So these are the three hormones which act through JAK-STAT pathway, okay. And this MAD pathway is activated by this Mullerian inhibitory substances and activin. So these are the hormone, Mullerian inhibitory substances and activin, okay. Okay. So these are the hormone name that you have to remember and the hormone receptor, okay. So done. Now two MCQs. First MCQ, serum level of one hormone X is recorded. So hormone X is recorded, and you can find out that this hormone level is fluctuating, very high level during exercise, very high level during sleep. So what is the hormone? This is a repeat question, I believe you know the answer, okay. So this is not the cortisol, this is not the insulin, this is the hormone which is nothing but growth hormone. So ग्रोथ हार्मोन का स्टिमुलस मैंने बार बार बोलता हूँ, बट एक क्वेश्चन मैंने पोस्ट किया था इंस्टा में, बहुत लोग गलत आंसर दे रहा था कि मैंने दिया था व्हिच ऑफ द फॉलोइंग इज द स्टिमुलस फॉर ग्रोथ हार्मोन. वन मैंने दिया फास्टिंग, सेकंड मैंने दिया था रेम स्लीप, थर्ड मैंने दिया था बोथ ऑफ द अबव, एंड फोर्थ दिया था नन ऑफ द अबव. फास्टिंग, रेम स्लीप, बोथ ऑफ द अबव, नन ऑफ द अबव. व्हाट विल बी द आंसर इफ आई आस्क यू अ क्वेश्चन व्हिच ऑफ द फॉलोइंग इज द स्टिमुलस फॉर ग्रोथ हार्मोन? फास्टिंग, रेम स्लीप, बोथ ऑफ द अबव, नन ऑफ द अबव. Fasting, yes. So see here, that is the only difference you have to remember here. For the growth hormone, REM is an inhibitory. Non-REM sleep is a stimulus for the growth hormone production, not the REM one. So whenever I give a option fasting, REM sleep, then REM is not a stimulus, only fasting is the stimulus. A will be the answer, okay. But most of the cases you cannot recall that REM tha ki non-REM tha. So you have to remember non-REM is a stimulus for growth hormone, not the REM. REM is a stimulus for LH, FSH, prolactin. REM sleep is a stimulus for this. REM is a stimulus for LH, okay, FSH, prolactin, okay. These are the three hormones which are stimulated by REM sleep, not by growth hormone, okay. And others, you know, fasting, all this thing, you know the stimulus for, okay. Very good, very good. And the last question, hormonal profile study shows of an adult is shown here. So again, this is a very easy question. So we all know that ACTH as well as cortisol, both of them follow the circadian rhythm. So you can find out here that there is a lowest level here and there is a highest level. So highest level you are getting almost in the morning, and the lowest level you are getting in the night, So this is typically following a circadian pattern, and this circadian pattern is for cortisol, okay. So this is cortisol. So this is all about the LRR session, okay. So thank you so much for listening, and I believe this will be helpful for you in the exam. So best of luck for your upcoming exam, and you will get the PDF in the PrepLadder app. The annotated PDF will be available there. So please do download the PDF from there and give a quick revision. Sir, if I do LRR out of 10 question physiology and exam, so see out of 10 question ऐसे तो कोई statistic मेरे पास नहीं है, but if you do the LRR in the short time, most of the important things you will cover up. So 80% generally we say that 80% तो आपका हो ही जाएगा. Thank you so much, dear. Thank you so much. Okay, not yet 7:30. Okay, 7:30 is almost 7:30. Okay, very good, Agnes. Chalo. So I think sets enough for FMG. Yes, enough LR. I mean, rapid division is. I mean, enough was a little bit difficult for me to say. If it is enough, then why I am taking the whole lecture of 70 or 60 hour, okay? But you can understand that most of the things will be covered up, okay? This is the things are understanding. Motivational power, it should come from within, motivations, okay? You think of yourself what you want to do, and that should give you motivation. Otherwise, the motivational speaker will give you the motivation for few minutes, and it will vanish in the next day. So it should come from within, okay? Okay. Thank you so much, sir. Thank you so much. Thank you. Bye bye. Take care.